One more time. Yes, I did. I'll come in just in a second. Okay. So here it is actually. This is the video I wanted to show you. To be going online. Okay. So let's go back here. So this is the most of the patient I get. You know, there's really no space left in the lateral recess or foramen. And if you look carefully, this is all what the foramen is at this corner. Now, forget about this. This is 5S1. That opens as well, but it is more shadowed by the ala and the iliac crest. But I want you to look at when this is a neuromonitoring probe. It's actually Jamshidi, but neuromonitoring probe is going to go in. Forget about this part. I want you to pay attention to this part. But here you see as well that's all. So this is a neuromonitoring probe. I go in, I go on the top, and then the sleeve comes down. I show it to you. K-wire goes in. Now look at what happens when the dilator goes in. It opens up the space. When it opens up the space, it actually opens the foramen, area of the foramen, as well as lateral recess. Amazingly, this patient wake up and the leg pain is gone. And I couldn't believe in that. That's why I started getting patient testimonial, literally letting patient talk. I mean, what does really matter? What is the goal of this patient? Let's stop this for a second. What is the goal of this patient? Some people say, no, seriously, some people say to correct the lordosis from 7 degrees to 11 degrees. They say that. Some people say fusion. But the real goal is for the patient not having the back pain on the leg, correct? This is the goal. It doesn't really matter how you achieve that goal. You know, you can, especially some elderly patient, for them to correct the numbers, you have to do so much bigger surgery. Okay. Now, look at that for a lateral recess foramen here. You see that there? And compare it now to how it was before. So we go back and forth between two shots here. Here, this is the lateral recess here after, and this is before. Look at that. Do you see what the difference is? And now, obviously, other people call it indirect decompression. I call it physiologic or anatomic decompression. And the goal is, to restore the disc base and the foramen to the time patient didn't have. Patient wasn't born with lateral recess stenosis, right? They didn't have this radiculopathy 20 years ago. They start having radiculopathy 2 years ago. Now, the minimalistic approach is to restore it, not how it was 20 years ago, but how it was 3 years ago, 2 years ago, before they start having symptoms. Now, if that is your goal, you can do so much less surgery to achieve that goal. If your goal is to restore the lordosis to the time they were 25 years old, that requires so much bigger surgery, and the risk versus benefit is all what's about. Now, which of you are going to correct so 40 degree or 50 degree scoliosis on an 88-year-old patient, 4-level fusion, with the cardiac issues, ejection fraction of 30%? Anybody is going to do that? I do it every day. They come from entire United States, and other surgeons tell them that they cannot have a surgery for good reason. They are good surgeons. They know doing that kind of surgery on an 80-year-old person with cardiac issues is going to kill them, literally going to kill the patient. Now, I do that surgery in 1.5 hours, send the patient home next day. They'll get ambulation, and do you know how they look like? Let me show you how they look like after I'm done with them. Okay, so, and by setting the goal at the level that is truly specific to that patient, and that's very important. Like again, you remember we talked about what are you trying to achieve? Correct scoliosis, correct the lordosis, or make patient ambulatory. This is my goal. Reduce their pain to as much as possible, and make them being able to do activity of daily living. This is a name we call it ADL, activity of daily living. We want them to be independent, ambulatory, and reduce the pain as much as possible. Now, all of a sudden, you don't have to do a T5 to S1 decompressional fusion. You can just do a 3-level fusion. That is a totally different story, extremely doable compared to, I have this blog on Facebook. And everything I show you, many of these cases are already there. And if you put the testimonial of that patient from Sioux Falls, it probably doesn't matter, I find it. So let's go back there. So, look out. So we have still time a little. Switch pages. So at this point, you should ask me all this question now, huh? Okay. So these are that is why lots of these patients do come from entire United States to me, because they are being told no by a local surgeon for good reason. And when they come to me, the first step is, what is the major thing that bugs you? Is it the leg pain? Is it the back pain? Is it the walking? Once you set up that goal, a realistic goals, and you see that you don't really have to do 5-level fusion. Sometimes I had a patient with a 65-degree scoliosis. His leg pain was the problem. I did a L5S1, just foraminotomy. And
something that I also think people living with that scoliosis or whatever problem it is for years ago, they're really adjusted to it, right? So you don't really have to correct everything that's wrong in a picture.
I'm going to show you exactly something regarding that. I just saw a patient who had an accident, who had a horrendous finding. I'm going to show you, and I put it on LinkedIn. Only 1 of 12 people asked, what are patient symptoms? Everybody else said you need to do a front and back. Open up the belly, do a corpectomy and so on. And I tell you what the patient's symptoms are, then it makes sense to you why maybe that approach is not the best. So, so I have about a few hundred cases on my Facebook blog. Let's see here. That spine and neurosurgery for patient. How did it choose that one? Let's go back here. That's not the one I wanted to go for. I want to go for neurosurgery case review. That's the one I wanted to show. So, do you guys do scoliosis and so on? Yeah. No. Yeah. No. There are sometimes, and there are scoliosis cases are very important, and all our knowledge is gained. I'm not myself. I don't call myself scoliosis surgeon, but my colleague, Dr. Kim, has been a scoliosis surgeon for 35 years. He does a lot of juveniles scoliosis and so on. And all the knowledge we have gained from scoliosis is from younger patients, juvenile school, because traditionally we never did scoliosis cases on 80-year-old people. Yeah. This is all knowledge is from younger people, and that is a problem there. Now, if you try to apply those knowledge from juvenile scoliosis to degenerative scoliosis, if you try to get those tenants from 1-to-1, then you're talking about different kinds of people. Now, this is the one I was talking about that I just put up not long ago. Yeah, I put it on, yeah. Yeah, and everybody look at that and says you need the front and back, and yes, Yes, you do need front and back if you are going to correct this. But I got a testimonial of this patient. Literally, this patient has L5 and S1 radiculopathy. This is thoracic. This is T11, T12. He's a farmer. When he was 12, he had an accident. For some reason, they decided they don't want to do anything. He healed. He has been working as a farmer for 35 years. And just with this, yeah. And, no, but and he's a very chunky guy. Actually, I got a very good testimonial. He lifts up heavy stuff. For 35 years, he has been living with that. His symptoms now is L5 and S1 radiculopathy. So he goes to Mayo Clinic. Mayo Clinic is one of the biggest places and so on. A very experienced surgeon. Look at this and now. You live with that for 35 years. Go live with that. Okay. The experienced surgeon goes away. A younger person takes over. The young person wants to do a 2-day surgery with a corpectomy and correct this. And he says, I was living with that, but my problem is my leg pain. And if you look at the CAT scan, to correct that, you have to do pit osteotomy in 6 levels. Now, if the patient is symptomatic, yes, but he's not symptomatic from this fix that is what we call fix the patient. Don't fix the pictures. Now, if you want to fix the picture, go to Photoshop. Just go and fix the picture like that. But look at that. He has a syringe. He got the syringosubacnoid shunt and so on. And this is his problem. So, do I need to correct that T11 thing and so on? And no, I don't. I can just do a 1-level OLLIF in 40 minutes and send him home same day with this. So once your goals are realistic, then you can as well, do a much smaller surgery. Now, another thing, so we are going to start in about 10 minutes, but this is just a preview of what we are going to do. Okay? What I want you to get specifically as well, look at this patient. And I have hundreds of these patients now. So I'm actually born in Iran, and I did actually 1 year in Isfahan, in Hazar Jarif. I did in Isfahan the 1 year, and they told me I'm not religious enough. They threw me out of university. So I came to Germany and I started my med school and did my PhD, and then 1999 actually I went to Stanford in California. Then I did 2 years of research. I just liked it. I knew I'm not coming back. So then I went to Dartmouth College, did 1 year of general surgery, and I went to Texas and I started all over again. It took me 13 years to finish my residency. And years ago, I would have done an open surgery for that. And this patient, let me tell you a little history about this patient. This patient drove 8 hours to come and see me from a different city. Has lots of cardiac problems. This is not a healthy patient. This is not a young scoliosis patient that you can do whatever you want to do. 3 local surgeons told her there is no way they can do anything for her. Not because they weren't good surgeons. They could do surgery. These are good surgeons, but they couldn't do it for this patient because the trauma of the surgery would be too much. Now, this patient quit walking for 6 months. She couldn't walk to the kitchen to make herself food. She lost 30 pounds, actually 40 pounds in 3 months. 40 pounds is about 18 kilograms or 17 kilograms. So she was 105 pounds, which is about now less than 50 kilograms. And you guys all know, 50 kilograms is a magical number. When people fall below 50 kilograms, your body shuts down. So she was in a bad situation. Now she was in a worse situation because of that. And then nobody could really help her. Now, this patient truly needed, she had symptom. I couldn't limit that. She really needed multi-level fusion. And that is what we got. Okay? The reason I could do this for her is because I didn't do the traditional surgery. Now, I put this picture out, and somebody says, look at the lordosis, you have flat back syndrome. Okay? So the alternative to this, it would be doing the regular surgery, do the pedosteotomy, do all the things to create that. But that surgery already was out of question. Now, this surgery was done, and I collect for 10 years. I've collected all my data. I have 43,000 follow-ups with all specifics on my patient. I have a database of almost 11,000 patients, 5,000 surgeries, 3,300 traditional cliff TILA, and meanwhile about 1,500 of OLLIF procedures. And the reason I could do this surgery is that surgery was under 2 hours, skin to skin, with blood of 230 cc. Now all of a sudden that surgery becomes 2 hours. So also you can help this patient. Now I want you to look at this patient. She's not 50 kilograms anymore. This is 4 months after the surgery. She can walk. 1 month after the surgery, the back pain subsided. The leg pain was gone. She woke up and the leg pain was gone, and I took a testimonial. This patient. Literally, I talked to the patient, and Amanda can send you the link of this patient. This is the patient. Almost you cannot tell which one is the patient, but this is the patient, okay? And the idea here is, all of a sudden you can help this patient. That you wouldn't have any other choice in any other way. Now, yes, I still do surgery on people your age group, or your age group, athletic people with a sport injury and so on and so forth. I do their surgery in 35 minutes. They go back to 3 days, they go back to work. Yeah, and I have my database, I have all the clinical results, but that is, sometimes it's not enough. Now, what I want to show you the next is, I think, truly summarize what's specific about this, that sometime in life you see something that, and I understand my colleagues, okay? Many of my colleagues, they listen to this and they say it's too good to be true. It's just that you did 5-level fusion, 5 cages, 12 screws under 2 hours with, a cup of coffee, blood loss, and patient in 1 month. This is something fishy about it. And regularly it is. Then let me tell you something. Why people think it's fishy? Something not right about it. Like, does anybody live you're in Zurich, right? You imagine you didn't know flying. Did you fly or did you take a fly? You did fly. But if you would take a train, how much would it be from Zurich to here?
8 hours.
8 hours? How long did you take it to fly? How long did it take you to fly? 1.5 hours? So now imagine you didn't know the concept of flying. And you would come to me and say, I got from Zurich to here in 1.5 hours, and I don't know airplane. I only know trains. I said, no, something is not right about it. Okay, so this is different concept of surgery, different way of surgery. And if you don't know it, if you apply the TLIF to a PLIF concept or other traditional concept to this, then it becomes something is fishy about it. But if you understand this is the first 7 minutes, my first cage is in. I will show you a video about that. If you understand that all the time for dissection falls away, there is no time for dissection. Then all of a sudden it makes sense why it's doable, and it's not doable for me now. This is something I go and tell everybody around the world, and I go and talk a lot of places. If you walk out of this room and think a boss is a great surgeon, you got the wrong message. Okay? Now, everybody can learn this by applying this algorithmic thing. You go from A to B and C and so on. Everybody in our group who have learned that within the 1/7 of my number has hit my landmark. And we gather those. We literally gather those in a big database that, it took me 180 cases to fall under 1 hour for 1-level fusion. Everybody who joins us falls within 10 to 15 cases fall below 1 hour. I just had a colleague, Dr. Gasco, in Texas, who did the one level in 47 minutes. Okay, so this is not my superior skills. And if you walk out of this room thinking about his superior skill, then you got the wrong message, okay? So, but what I want to do here, this is YouTube, accessible to everybody, right? I'm just going to put OLLIF, enter. Now, I'm going to tell you that you can just sit for a full hour, just scroll down. At first, there are some other stuff, but you can just sit for a full hour. These are my patient testimonials that up there. And then when you come down a little, after some other thing, then you scroll down, OLLIF. These are all my patients. I have over 1,200 patient testimonials who tell you that they woke up and their leg pain is gone. That is all I need to know. Okay, so certainly, not everybody is a statistic. What we do is a statistic. Not everybody get better, but and many of them are people who have been told no by other surgeons. So my patient population is not the regular fusion patient population. Is practically the reject of many other surgeons, but. And most of that, you see my shaky video, I'm sitting there, I'm busy, but I still take my time to take the testimonials because this is really what matters. People who have been told no, and I'll come on camera, they woke up and the leg pain is gone. And that is all, this concept of what other people call indirect decompression. By the way, one of my answers to people who say, they don't believe in indirect decompression is that you do ACDF. Anybody who does ACDF must believe in indirect decompression because 9 out of 10 times, you must be a really brave person if you go with something into the foramen and take big bites there. Okay, your vertebral artery. Most of us rely on putting a cage and lifting up, and you don't even need to do much. As a matter of fact, we just talked about that. If you do too much, you create C5 palsy and all the problems and so on. Most of the time, just a few millimeters is enough to decompress. So, and that's what it is. Now, this is exact. I think it's getting 1 minute. So I'm going to stop here and pass it on to however we are going to start the process. So this was only the preview. Okay.
Vielen Dank. Im Grunde genommen ist ja schon alles gesagt.
Ja, genau.
Ja, was man jetzt ja noch ergänzt, das war ja schon mal ein sehr guter Überblick über das, was machbar ist. Ich bin herzlich willkommen. Erste Stelle. Vielen Dank für die freundliche Unterstützung. Ja, ein Teil haben wir sozusagen schon verbracht gestern Abend. Wir hatten nämlich einen wunderbaren Dinnerabend. Wir haben gute Gespräche geführt. Wir haben Gäste, die von weit herkommen. Ich denke, wir von South Africa. Ja, weite Anreise. Vielen Dank, dass Sie gekommen sind. Zürich, Herford, Düsseldorf habe ich jetzt gehört. Wunderbar. Und ja, und dann wir hier bei Regio-Kliniken. Ja, also vielen Dank auch Jens und Amir für das Organisieren der Veranstaltung. Und ja, meiner Person, also ich bin jetzt hier seit 18 Jahren Chefarzt, habe die Wirbelsäulenchirurgie hier aufgebaut. Davor war ich 10 Jahre Oberarzt am Norddeutschen Sklerosezentrum und ja, da habe ich mich vorwiegend so mit jugendlichen Deformitäten beschäftigt. Die Versorgung von älteren Patienten haben wir auch gemacht, aber das ist etwas, was so in den letzten 2, 3 Jahrzehnten also mehr Platz eingenommen hat. Ja, also das ist ja auch der Grund, warum, sagen wir mal, auch in der Nachbarschaft hier in Hamburg an jeder Stelle letztendlich Wirbelsäulen operiert werden. Also die Verdichtung hat doch enorm zugenommen. Die Operationszahlen sind also exorbitant in die Höhe geschnellt an Operationen. I think it's the same in the US. Yes. Und was ich machen möchte, ist, dass ich einen ganz kleinen, vereinfachten Rückblick geben möchte über 30 Jahre Wirbelsäulenchirurgie, und zwar nicht komplett, das würde absolut den Rahmen sprengen, sondern nur den ganz kleinen Teil des lumbosakralen Überganges. Und der ist schon komplex genug, wenn man das richtig angehen möchte. Es geht also Surgery of the Low Back Pain zur Einführung. Also wir kennen das ja. Es gibt zwei Gruppen. Einmal ist das der akute Kreuzschmerz und es gibt den Kreuzschmerz, der chronifiziert ist. Chronifiziert, das wissen wir auch, mehr als 3 Monate Schmerzen im Kreuz, dann sprechen wir von der Chronifizierung. Das heißt nicht, dass die eine Gruppe die bessere oder die schlechtere ist. Aus beiden Gruppen kann es durchaus zu guten Operationsindikationen kommen. Und wir haben in der Wirbelsäule verschiedene Strukturen, die Ursache für diese Schmerzen sind. Das ist der Knochen, es sind die Gelenke, es ist die Bandscheibe als solches. Und das, was eben wichtig ist, das ist hier gelb gezeichnet, das ist das Nervensystem, das sind die Nervenwurzeln, die wir, sagen wir mal, zu Beginn der Wirbelsäulenchirurgie als Orthopäden eher vernachlässigt haben. Und in der Folgezeit, also erst sagen wir mal so richtig Ende der 90er Jahre, haben wir Orthopäden da mehr Augenmerk drauf gegeben. Ja, dass wir gesagt haben, Moment mal, das ist doch nur, es ist mehr als nur Knochen, ja, sondern zwischen den Knochen, da läuft ja auch noch der Nerv längs, und da haben wir uns überlegt, wie können wir die Situation der Engpasssyndrome besser in den Griff bekommen. Da waren uns die Neurochirurgen schon deutlich weiter voraus. Und ich muss auch sagen, in meiner persönlichen Historie haben die Neurochirurgen mir sehr viel geholfen. Ja?
Und vice versa.
Ja, die haben mir also für einige Sachen die Augen geöffnet. Ja? Das konnte man dann sehr gut umsetzen. Und die Neurochirurgen, die haben immer nur gestaunt, wie ich die Schrauben setze. Ja? Weil das völlig unklar war. Ja? Wie der das macht, ohne dass er irgendwo sich Hilfsmittel besorgt, wie zum Beispiel Röntgen. Ja? Also das kennen wir alles, Ligamente, Muskel, Facet Joints und Intervertebral Disc. Das sind alles die Probleme um die Wirbelsäule herum. Nochmal zur Einteilung, was wichtig ist. Die sogenannte Instabilität. Das ist etwas, was man im Auge behalten muss. Nämlich diese Erkrankung der degenerativen Wirbelsäule, die durchläuft verschiedene Phasen. Und das trifft jeden von uns. Wir haben in der ersten Phase leichte Veränderungen und an den Gelenken und an der Bandscheibe. Ja. In der zweiten Phase kommt es zur ersten Reduktion der Bandscheibenhöhe und dadurch kommt es zu Veränderungen im Bereich der Stabilität der Gelenke, rutschen ein bisschen auseinander. Die Gelenksspalte klaffen. So etwas kann man schon ganz gut im CT oder auch im Kernspin kann man das gut erkennen. Auch im Röntgen kann man eventuell schon mal so eine kleine Veränderung, entweder eine Ante oder eine Retrosysthesis erkennen und in welcher Phase sich dieser Patient dann eventuell befindet. Es endet dann irgendwann, in einer Degeneration der Facetten. Das heißt, die Facetten, die verklumpen, die werden größer und sind vergröbert. Und dann kommt es halt eben, wenn es dann soweit ist, zu diesen lateralen Stenosen, Foraminalstenosen, die dann die Probleme bereiten bei den Patienten, also ausstrahlende Schmerzen ins Bein. Ja? Und da setzt dann sozusagen bei uns die Indikation an, dass wir sagen, da müssen wir operieren, eventuell erstmal nur mikrochirurgisch, durch Dekompression oder halt eben, wenn es zu größeren Verschiebungen kommt, dann auch in der Phase 3 der Stabilisierung dann durch Reposition. Also die dritte Phase ist dann sozusagen das Endstadium, dass die Arthrose dann so weit fortgeschritten ist und die Wirbelkörper dann dermaßen aufeinander sitzen, dass es eigentlich nicht mehr zu einem weiteren Verrutschen kommt. Zum Beispiel, wenn die Bandscheiben parallel oder die Wirbelkörper parallel aufeinander sitzen, dann ist das schon immer im Grunde genommen eine ziemlich rigide Situation, wo man sich sehr wohl überlegen muss, ob man da noch ran muss, ob man das noch aufrichten muss oder ob man das nicht so lässt. Nämlich, es ist so, es ist unterm Strich die wohltuende Einsteifung der Wirbelsäule im zunehmenden Alter. Ja, wenn jemand also Zeit und die Muße hat bei Kreuzschmerzen, dann soll er einfach abwarten. Dann kommt es in der Regel, in den meisten Fällen, zu einem guten Ausgang. Leider ist das nicht immer so. Und genau diese Fälle müssen wir herauspicken. Und dann ist es nicht so, wie das hier zum Beispiel bei uns in Deutschland, es findet so eine Hetzkampagne statt. Ja, es wird zu viel operiert. Das ist nicht richtig. Es wird nicht zu viel operiert, sondern es wird zu wenig operiert in Deutschland. Das Richtige wird zu wenig operiert. Und das Falsche wird zu viel operiert. Das ist es. Und das muss man eigentlich überbringen. Ja, genau das ist die Situation. Und wenn man immer nur das Richtige aussucht, und das ist schon schwer genug, dann liegt man eigentlich immer richtig. Ich gehe mal weiter. Die Indikationen letztendlich haben wir eben ein breites Potpourri schon gesehen von dir. Also das ist auch hier bei uns so. Das ist natürlich die Degeneration. Dann kommt es zur Spinal Stenosis. Dann haben wir das Wirbelgleiten mit dabei und halt eben auch die diskogene Skoliose. Ich habe schon einige Bilder da eben gesehen. Ja, die diskogene Skoliose, die De Novo Skoliose ist ein Thema. Ja, die De Novo Skoliose hat ja nicht nur, sagen wir mal, die Seitverkrümmung als Problem, sondern ich habe das eben schon gesehen, sondern auch das sagittale Profil. Ja, ist problematisch. Ja, und das verursacht ganz andere Problematiken, die man dann auch chirurgisch angehen muss, zum Beispiel mit einer Osteotomie. Das war eben schon Thema. Ne? Dann haben wir das Posttraumatische, was man mit berücksichtigen muss. Und dann haben wir natürlich Autoimmunerkrankungen und die ganzen entzündlichen Veränderungen und die tumorösen Erkrankungen, die eher, sagen wir mal, im unteren lumbosakralen Übergang hier eher eine Seltenheit sind, muss man sagen. Auch Posttraumatic Instability ist auch eher, sagen wir mal, ein seltenes Erscheinungsbild im Bereich des lumbosakralen Übergangs. Aber alles das hier, was da drüber steht, ist, sagen wir mal, von großer Bedeutung. Was natürlich auch, sagen wir mal, unsere alltägliche Arbeit, und das haben wir heute ja auch, eine Revisionsoperation gemacht. Das sind halt eben hier diese Jason-Pittman-Syndrom und Post-Disc-Ectomy-Syndrom und Sutter-Jones. Das sind alles so diese Probleme, die wir also jetzt zunehmend immer häufiger versorgen. Ja, hier jetzt, so habe ich 1995, als ich dann anfing als Oberarzt in dem Skoliosezentrum, das ist das, was man mir an die Hand gegeben hat. Also ein Chisel und ein Hammer. Ja? Mehr hatte ich nicht. Und damit haben wir Wirbelsäulenchirurgie betrieben. Und auch nicht schlecht. Es ist natürlich auf einem anderen Niveau gewesen, aber wir hatten auch Zeit. Wir konnten uns die Patienten aussuchen und wir hatten Betten und Schwestern jede Menge. Das heißt, ob ein Patient nun 3 oder 4 Wochen bei uns liegen muss oder nicht, das war jetzt eigentlich nicht so von Bedeutung. Ja? Dass ein Patient heute nach 5 bis 6 Tagen nach Hause muss, ist halt eben eine neue Situation und darauf hat man natürlich medizinisch wie auch wirtschaftlich dann reagiert. Also, was haben wir gemacht? Wir haben den Knochen dargestellt, wir haben den Knochen eben, der durch Veränderungen halt eben auch die Schmerzen verursacht, den haben wir freigelegt, wir haben ihn dekortiziert und wir haben Knochen angelagert. Ja? Und diesen Knochen, den haben wir uns dann zusätzlich immer noch vom Beckenkamm geholt. Das war, ich sage mal, frische Muttererde, die wir dann aufgebracht haben. Und das kam dann auch zu einer guten Ausheilung. Also es ist wirklich so, dass dieses Verfahren auch nach wie vor seine Bedeutung hat. Ja, nicht überall kann man Cochlear-Implantate verwenden, sondern es gibt sicherlich auch Regionen in der Welt, wo man sagen würde, da wäre so etwas noch möglich, ja, so etwas zu operieren. Also nur mit Hammer und Meißel an der entsprechenden Stelle sozusagen die Versorgung vorzunehmen. Vorausgesetzt immer gute Indikationen. Und jetzt sehen wir nochmal hier auf diesem Slice, sehen wir jetzt das, was gemacht wurde. Das ist hier links der Zustand vor der Operation. Ich habe das mal mit einem Bleistift hier so angezeichnet. So haben wir übrigens damals immer unsere Bilder geplant. Ja, wir haben also immer mit dem Bleistift auf dem Röntgenbild, das ist tatsächlich original aus der Zeit, haben wir uns dann so das angezeichnet und haben gesagt, da und da muss Knochen hin. Oder wenn wir ein X hatten, da kam dann da, sollte dann da eine Schraube hin. Die Schraube zu diesem Zeitpunkt hatten wir natürlich schon. Ja, aber die Schrauben haben wir nicht für so etwas benutzt, sondern diese Schrauben haben wir benutzt zur Korrektur von Deformitäten, also für Styloseoperationen. Ja, da haben wir Schrauben gehabt. Natürlich hatten wir die Schrauben. Wir sind sogar auch damals mit in der Entwicklung von diesen Schraubensystemen in einem erheblichen Maß beteiligt gewesen. Über Synthes haben wir also diese Entwicklung der Schrauben vorangetrieben, aber trotzdem haben wir so etwas operiert. Ja, und jetzt sieht man hier auf der rechten Seite, sieht man also jetzt die angewachsene Knochenmasse. Das heißt, das Ergebnis der Fusionierung, also der Stabilisierung, ist vollumfänglich umgesetzt. Und zwar nicht durch die Schraube, sondern durch Knochen. Und es ist auch so, heutzutage ist es immer noch so. Es ist also nicht die Schraube, die fixiert dauerhaft, sondern es ist die Spondylodese der Knochen. Ja? Die Konsolidierung des Knochens. Das ist das Entscheidende. Und die Schraube ist letztendlich nur ein Hilfsmittel für den Übergang bis zur kompletten Ausheilung der knöchernen Spondylodese. Und die dauert nun mal, so wie das ist beim Knochenbruch, seine 4 bis 6 Monate. Schneller geht das nicht. Und die Zeit muss man einfach haben, gibt es ja jetzt nicht mehr. Also hier, das ist ein wunderbares Operationsergebnis. Und eigentlich auch Standard. Ich würde jetzt nicht sagen, dass das etwas ist, was jetzt außergewöhnlich gut aussieht, sondern so muss das aussehen. Die Voraussetzung war absolut penibles Operieren. Also allein das Putzen, das Freilegen, das können Sie gar nicht kennen. Allein von der Altersstruktur her können Sie das gar nicht wissen. Also dieses penible Freilegen der Corticalis, ja, das hat Stunden gedauert. Also mein Chef damals, der hat für sowas, der war mit so einer Sache dann 13, 14 Uhr fertig. Wir haben heute den Telef, haben wir gemacht, haben wir kurz nach 9, halb 10 haben wir Schnitt und kurz vor 11 waren wir fertig, ne? Mit einem Drum und Dran. Ne? Also unvorstellbar, ne? Unvorstellbar. Aber dieses penible Operieren und das Freilegen, es musste wirklich alles komplett frei sein. Und zum Beispiel die Fascia intertransversalia durfte man überhaupt nicht verletzen, weil auf dieser Fascia transversalia, also das ist so eine glänzende, spiegelnde Faszie zwischen den Querfortsätzen, die musste man freilegen und da lag dann auch der Knochen drauf, beziehungsweise auch jetzt liegt er da immer noch drauf. Ja? Und da hat er sozusagen eine wunderbare Grundlage, um dann sozusagen mit dem Prozessus hier zu verwachsen. Also das hat geschult, auch wenn man dann auf Dauer seine Krampfadern aufgrund der langen Stehzeiten bekommen hat. Aber das ist halt eben Wirbelsäule. Das ist Wirbelsäulenchirurgie gewesen. Ja, und dann im Laufe der Jahre hat man sich dann überlegt, naja, es wäre vielleicht doch eine schnelle Mobilisierung besser und hat dann auch angefangen, Schrauben zu setzen. Das ist aber, sagen wir mal, dann so, ja, Ende der 90er Jahre ist das natürlich der absolute Standard gewesen, dass man erstmal zusätzlich hinten verschraubt hat. Das ist noch das Click-X-System von Synthes, also an dem sind wir da damals mit beteiligt gewesen. Hatte ich ja heute schon gesagt, haben wir darüber gesprochen. Ne? Das ist ein System, was jetzt eigentlich auch schon wieder komplett vom Markt ist, auch schon 15 Jahre gar nicht mehr gibt. Aber was wollten wir damit erreichen? Also a faster remobilization and increased fusion rate. Das würde ich mal sagen, kann man sagen, ja, hat funktioniert. Aber, und das ist auch nach wie vor, ist es gültig, und das ist auch über so Megastudien ist das also auch immer wieder herausgearbeitet worden, bezüglich des klinischen Outcomes. Keinerlei Vorteile, keinerlei. Immer die richtige Indikation vorausgesetzt. Und das muss man natürlich dann jetzt auch sagen, die richtige Indikation, das ist jetzt ein ganz entscheidender Punkt. Die richtige Indikation ist halt eben der reine Rückenschmerz. So. Und wenn wir uns alle überlegen, was ist eigentlich, wie viel Prozent unserer Patienten beklagen den reinen Rückenschmerz, dann würde ich mal sagen, ist das eher weniger. Ne? Sondern es kommt halt eben der Beinschmerz mit dazu. Und die reine Spondylese versorgt durch, also die reine Spondylese ohne Instrumentation mit Rückenschmerz kann natürlich eigentlich nicht zum Erfolg führen, weil sie ja irgendetwas machen müssen. Sie müssen entweder vorweg destabilisieren, indem sie eine Vasektomie machen, ja, oder eine Hemilamenektomie machen oder sonstiges. Und sie nehmen also Knochen weg, Knochen, der hält. Ja, das kann also letztendlich dann auch nicht zu einem sehr guten Ausheilungsergebnis kommen. Und da kommt jetzt halt eben die Schraube ins Spiel, beziehungsweise die Implantate. Das ist ja nicht nur die Schraube. Das ist jetzt sozusagen der Anfang, wo wir dann gesagt haben, jetzt verschrauben wir das alles. Und dann waren wir ganz froh, dass wir diese Patienten dann sozusagen nach 3 Wochen hatten. Ja, das war schon mal also ein ganz enormer Fortschritt. Und dann kam etwas, wo ich mal sagen würde, da kam dann der Sportler bei dem Wirbelsäulenchirurgen durch. Und zwar haben wir dann Zugänge gelernt, die wir dann einfach alle ganz toll fanden. Und zwar, das waren diese minimalinvasiven Zugänge, transperitoneal und retroperitoneal. Also nur noch kleine Schnitte vorne. Und über diese kleinen Schnitte haben wir dann letztendlich Metaware, den sogenannten Harms Cage, den haben wir dann mit einer einfachen Zange immer so zurechtgeschnitten und haben den dann also von ventral in die Bandscheibenfächer eingebracht. Ja? Und wir fanden das eigentlich immer ganz toll, solche Eingriffe, weil das wirklich spannend war, ne? Das zu operieren. Und letztendlich gehörte auch enorm viel Know-how dazu. Einmal bezüglich der gesamten Ausstattung der Klinik, wie auch bezüglich der Ausbildung der Chirurgen. Und wir waren dann auch für eine Zeit so weit, dass wir also letztendlich 3 Operateure hatten, die das also tatsächlich so am Fließband dann operieren konnten. Ja, und das war auch zeitgleich diese Entwicklung dieser Zugänge mit der Entwicklung von Bandscheibenendoprothesen. Und dann haben wir angefangen, Bandscheibenprothesen einzubauen über diesen Zugang. Ja? Und das haben wir dann tatsächlich ein paar Jahre betrieben, bis wir dann so gemerkt haben, bis wir dann auch selber an unsere Grenzen gekommen sind. Und ich mir dann auch überlegt habe, ja, was ist denn wenn? Was ist denn wenn? Und dieses wenn wäre zum Beispiel oder ist auch gewesen, ich habe das alles durch, wenn es zum Problem kommt. Ja, schwerste Blutung und Lockerung und Pseudarthrose, also Dislocation und Pseudarthrose. Das erfordert einen absolut breiten Rücken und extrem gute Nerven. Und wenn man das hinter sich hat, ein paar Mal, dann überlegt man sich, das waren nicht nur wir, sondern der Jasinski hat das, ne, den Sie ja persönlich sogar noch kennen, so wie ich das richtig verstanden habe, der wird sich das auch überlegt haben. Ja, pfiffiger Mann. Zeigt gleich noch das Original, habe ich nämlich von ihm auch, ja, gelernt. Nicht, weil ich ihn persönlich kannte, sondern ich habe es einfach, mich hat es also fasziniert, wie der das dann gemacht hat. Und dann habe ich das halt eben, das hat man früher alles irgendwie autodidaktisch dann gemacht. Heutzutage geht das ja auch schon nicht mehr. Aber man ist dann davon abgekommen, von diesem ventralen zusätzlichen Zugängen, so sah das aus. Links ist das immer so schematisch dargestellt. Das sind die Retroporen, da haben wir schon heute drüber gesprochen. Das war der gesamte Zugang. Mehr tatsächlich nicht. Aber hier auf der Höhe, Ureter, dann haben wir hier die ganzen Blutgefäße hier einmal herum. Das ist L5 bis 1. Ja. Und das ist schon stark an den Gefäßen vorbei. Und ein kleiner Schnitt daneben und man hat also ein Riesenmalheur. Das darf man einfach nicht vergessen. Und wenn man dann in der Peripherie operiert und kein großes Klinikum mit allem drum und dran dabei hat, dann ist das problematisch. Das muss man schon sagen. Ne? Ich habe das hier unten auch nochmal aufgeschrieben, obviously a challenge of a resurgent. Und da unten der Satz ist auch nochmal relativ wichtig. Ja, you need a lot of experience in general and particular abdominal surgery. Also das ist tatsächlich absolute Voraussetzung, wenn man da ran will. Ne? Und dann gibt es natürlich einige Kliniken, die nehmen sich dann immer die entsprechende Fachdisziplin mit dazu. Also wir haben einen General Surgeon mit dabei. Das ist nicht der Weg. Der Allgemeinchirurg, der hat nicht den Fokus auf das, was losgeht. Und der findet sich auch, sagen wir mal, bezüglich des retroperitonealen Zugangs, der ist für ihn völlig unüblich. Ja? Das heißt, wenn er den ich habe das beobachtet, ja? Ich habe es gesehen, der findet den Ureter nicht, retroperitoneal, der findet ihn nicht, der weiß nicht, wo er ihn zu suchen hat. Ja? Wenn er seinen Zugang wählt, dann findet er ihn sehr wohl, aber nicht hier unseren, ne? vom Feindsatz. Ne? Also das sind echte Probleme. Ne? Deswegen ist das nicht verlässlich und ich würde es auch nicht machen. Ja, 2 verschiedene Fakultäten, wenn die eine Sache operieren. Das muss man dann schon aus einer Hand machen, ja, und dann kriegt das auch Sinn. Ja, und man muss es ständig trainieren. Das ist also eine Sache des Trainings, wie gut man ist. Ich habe hier nochmal Advantages und Disadvantages gegenübergestellt. Also der Vorteil, also bezüglich der zusätzlichen ventralen Abstützung ist also Outcome, ist ohne Frage noch viel schnellere Konsolidierung der stärkeren Spondylese. Man hat eine sehr gute Möglichkeit der Korrektur und Distraktion, also Distraktion auch noch mit ventraler Abstützung. Ja, und das ist mir auch nochmal wichtig. Der dritte Punkt, das ist jetzt, sagen wir mal, wieder der Aspekt des Orthopäden. Das ist beim Neurochirurgen nicht so im Blut drin, aber das sagittale Alignment, das ist also von ganz enormer Bedeutung, dass ich da wieder ein gutes Profil habe. Ja, und da haben wir dann angefangen, dass wir gemerkt haben, ja, wir kriegen das Profil ja wieder korrigiert. Ja, zwar mit sehr viel Aufwand, aber wir kriegen wieder ein Profil, so wie es sein muss. Ja, wir haben sozusagen das Sagittal Slope of the Sacrum, konnten wir wieder richtig korrigieren. Ja, alles so Sachen, wo wir dann überlegt haben, wie kriegen wir das hin? Ja, mit diesen Zugängen haben wir das hinbekommen. Aber jetzt zu den Nachteilen nochmal. Das ist ein zweiseitiger Eingriff. Wir haben es teilweise auch zeitig gemacht, also zweiseitig. Ja, dann waren wir so schnell, dass wir das also einseitig hinbekommen haben. Ja, aber trotzdem sind wir bei Operationszeiten dorsoventral so bei 5 bis 6 Stunden. Ja, das geht ja gar nicht. 5 bis 6 Stunden an einem Patienten herum zu operieren, das geht nicht. Ne? Also Extended Surgery Time, High Demands of Tools. Was ist damit gemeint? Also aufbauen, abbauen. Jede Menge, doppelte Menge an Sieben, an Containers. You have to open and the price of one container is 80 euros. 80. Yeah. So you can reduce the cost by from the back. And unten habe ich nochmal aufgeschrieben, severe complication by injury, ureter, intestines and veins. Yeah, that's a problem. Here we have dislocation pseudosclerosis, and das fordert Nerven, das zu korrigieren. Und so einen Patienten, den können Sie nicht nach Hause stecken. Da können Sie nicht sagen, naja, das wird schon, das verheilt schon irgendwie, ja. Da müssen Sie ran. Und Sie können auch nicht sagen, fahr mal weiter. Das macht der andere schon. Nein, der bleibt bei einem selber. Ich kann auch nicht zu meinem Kollegen sagen, mach das mal bitte. Und ich habe das eingebaut und ich muss das machen. Und alles das müssen Sie in der Indikationsstellung im Kopf haben. Ja, was ist, wenn? Also Sie dürfen niemals mit dem Rücken zur Wand stehen. Ja, sondern Sie müssen immer sozusagen den Plan B haben. Plan B. Ja, und jetzt kommt der TILIF. Das ist er. Das ist jetzt Original Jasinski, TILIF. Ja, das war the beginning, das ist also wir hatten damals noch nicht diese speziellen Implantate, als wir damit angefangen haben. Das heißt, wir haben auch wieder den sogenannten Harms-Cage, das ist sozusagen der Chef von ihm gewesen. Das ist in Deutschland sozusagen der sozusagen das alles entwickelt hat. Und deswegen heißt er auch noch Harms-Cage. Ich nehme auch den Namen weiter, einfach, weil ich diesen Herrn sozusagen immer präsent haben möchte. Auch wenn ich diesen Harms-Cage jetzt nicht mehr benutze, ich habe ein Einschlaginstrument, ein Detektor, sodass dieser Mann Harms bei mir immer präsent ist weiter. Ja? Und das möchte ich auch, dass das so ist. Ja? Er hat nämlich damit angefangen. Das ist der sogenannte Harms-Cage, das ist der Original-Cage. Den haben wir dann eigentlich von dieser Größe her von der Halswirbelsäule eingebaut. Ja? Und jetzt haben wir angefangen, über eine beidseitige Facetektomie die Bandscheibe freizulegen und diesen Cage einzubringen. Und er stand sozusagen immer in der Mitte, in der mittleren Säule. Ja, und hier vorne haben wir Knochen reingesteckt. Das ist jetzt optimales Ergebnis. Damals gab es noch das Synthesis-System, einschließlich des Mikro-Harms-Cages. Und eigentlich gutes Ergebnis. Eigentlich gutes Ergebnis. Da waren wir schon mal zufrieden. Jetzt kann man natürlich fragen, zwei TILIFs. Twice. Ja, das to me had to be carried out twice. Ja, ging nicht anders. Warum? Weil die Industrie aber noch nicht nachgekommen ist. Und wenn ich jetzt höre, damit hat, is it right? You have 8 engineers only working for you for development of new implants.
I have the machine building them right in the bin.
Yeah. That's fine.
I can do this.
Ja, das hatten wir nicht. Und jetzt ging es los mit den Implantaten. Ja, jetzt hatten wir also richtige ventrale Abstützimplantate sozusagen in dieser Bananenform. Ja, und das ist jetzt hier eine isthmische Spondylolisthesis. Das ist hier Grad 2 bis 3. Und das ist alles von hinten operiert mit einem sehr guten Korrekturergebnis, komplette Position. Und früher, also vor Perfektionierung, das ist schon TILIF perfektioniert. Ja, sowas kriegt man nicht hin, wenn man den TILIF 50, 100 Mal gemacht hat. Ist das Ergebnis noch nicht erreichbar. Davor war es eigentlich sicherer, eigentlich selbst bei dem Grad 2 bis 3, dass man das dreiseitig operiert hat. Nicht zweiseitig, sondern sogar auch dreiseitig. Ja? Man hat hinten angefangen, ja? Ein Release gemacht und Setzen der Schrauben, komplettes Release, ja, von hinten mobilisiert. Und dann hat man den Patienten umgedreht und hat hier Mist von vorne gemacht und hat die Bandscheibe ausgeräumt und komplett mobilisiert, also ein ventrales Release. Ja, man hat den Cage dazwischen gesetzt, dann hat man wieder, aber Voraussetzung war ventrales Release, musste man vorweg ein dorsales Release gemacht haben, komplett, sonst hätte der Wirbel nicht zurückrutschen können. Das auch immer nur mit Kompromissen. Ja, und zum Schluss, also zweiter Zugang, ventrales Release mit Cage-Implantation und als drittes dann nochmal wieder umdrehen und fixing the screws by groups. Als drittes. Das hat nun auch wieder den ganzen Tag gedauert. Ne? Hat in jungen Jahren vielleicht ein bisschen Spaß gemacht, aber dann auch irgendwann nicht mehr. Ja, also ist man auch, hat man sich dann überlegt, da steht 5 bis 6 Stunden Session Time, und dann hat man sich dann irgendwann überlegt, das kann es dann auch nicht sein. Ja, und dann hat man sich, das ist dann aber sozusagen dann auch die Spitze, warum das noch mit rein? Obwohl zur Pathologie schon eine Liste ist, gehört auch mit dazu, dass die Interartikularportion beziehungsweise das Gelenk L4, L5 und die das also häufig operieren, die wissen das ganz genau, dass es auch dysplastisch das Gelenk 4, 5 ist genauso dysplastisch wie das Gelenk 5 ist 1 und deswegen kann man es auch durchaus mitnehmen, aber das, ja, heutzutage gucke ich mir das immer erst einmal an und operieren, wie das aussieht, dass man es dann entscheidet. Jetzt kommen wir aber nochmal zur operativen Vorgehensweise des TLIFs. Das ist also der generelle Zugang über Wilson, also lateral zwischen den Muskelbeuteln von Longissimus dorsi und Iliocostalis. Ich komme also über diesen Zugang durch die Faszie, durch die Faszienlücke, komme ich also direkt auf die Prozessus intertransversalia und oder transversalis und habe dann sozusagen die Eintrittspunkte für die Pedikelschrauben. Nicht? Das haben wir heute auch gemacht. Das ist relativ schnell gemacht. Und dann braucht man letztendlich 3 Meißelschläge. 2 für die untere Facette am oberen Wirbel und 1 Meißelschlag für die obere Facette vom unteren Wirbel. Wenn man das gemacht hat, ist dann der Zugang frei zur Bandscheibe. Diese wird dann inzidiert. Zu dem Zeitpunkt sieht man noch nicht den Nerv. Der Nerv ist in der Regel noch bedeckt von Fettgewebe und Kapselgewebe. Und es ist auch besser, man sieht ihn erstmal nicht. Und es ist immer das Gleiche. In dem Moment, wo das Bandscheibenfach ausreichend ausgeräumt ist und distrahiert ist, taucht er auf einmal auf. Und dieses Aha-Erlebnis hatten wir ja auch heute, ne? Auf einmal ist er da. Und wenn man den Nerv dann sieht, ohne dass man ihn aktiv gesucht hat, weiß man genau, jetzt hat man das Bandscheibenfach also ausreichend gut präpariert und freigelegt. Dann, also es wird dann komplett ausgeräumt und der Knochen wird vorbereitet durch bestimmte Küretten und Kümmern. Ja. So sieht das dann aus. Ne? Der Knochen wird also aufgebaut. Vorstellung ist, dass man dann das Bandscheibenfach komplett mit Knochen auffüllt und dann in diese Knochenmasse dann den Cage impactiert. Jetzt ist es so, also es hat sich gezeigt, es reicht, wenn man den Knochen also sehr, sehr sauber präpariert. Also das Cleaning-Off ist also extrem wichtig des Bandscheibenfaches, ja, ein Aufrauen und es muss blutender Knochen sein, der darf nicht verletzt sein, der muss aufgeraubt sein. Ja, und in diese Situation stellt man den Cage, ja, und dann hat er ein sehr gutes Einwachsverhalten. Ja, wird dann sozusagen vom Knochen angenommen, ohne dass man dann sozusagen den Heiligenschein oder halt eben einen Lysesaum um das eingebrachte Implantat herum sieht. Ja, und das ist letztendlich, wenn man sich daran hält und sehr sorgfältig mit den Deckenplatten umgeht, ist das also eigentlich sehr gut so. Und jetzt haben wir hier sozusagen nochmal, ich will mal sagen, das ist jetzt das Ergebnis 30 Jahre Erfahrung in der, speziell in dieser sehr eng gefassten Indikationsstellung für eine Spondylese. Das ist jetzt sozusagen absolut High-End-Ergebnis, so soll es sein. Das ist jetzt also wieder Meierding 2 bis 3. Es sitzt komplett aufeinander. Zu meinen Anfängen, also ungefähr, was weiß ich, 20 Jahre vorher, Für solche Operationen hätte man 6 Stunden gedauert. Das ist jetzt 2 bis 3 Stunden. Das ist monosegmental, komplettes Repräsentationsergebnis. Ja, und wie läuft das nun? Dann habe ich hier das nochmal gezeigt. Ist jetzt also eine Repräsentationsschraube, die Wirbelkörper drüber. Früher habe ich das drinnen gelassen. Das kommt jetzt wieder raus. Das ist also nur eine kleine kurze Schraube. Da lege ich also ziemlich locker einen Stab ein und über den Stab erfolgt dann mit speziellen Retraktoren dann die Reposition, dass das dann das Ergebnis ist. Ne? Also es setzt halt eben schon voraus, dass man sein Handwerk perfekt beherrscht. Es geht nicht anders. Ja, und es hat auch keinen Sinn. Das Ergebnis muss so aussehen, weil Sie sonst mit dem Alignment nicht zufrieden sind und der Patient wird dann auch nicht zufrieden sein. Und was passiert? Dann kommt es zum Stab- bzw. Schraubenbruch, wenn es eben nicht übereinander ist und wenn Sacral Slope halt eben nicht korrekt korrigiert ist. Ja, dann haben Sie dieses Implantatversagen und dann ist es nicht Pech, sondern dann ist es einfach nicht hinreichende chirurgische Versorgung. Also das muss man gewährleisten. Es heißt jetzt nicht, dass das immer so aussieht. Ja, das will ich damit nicht gesagt haben, aber es muss das Ziel sein. Man muss also quasi an 100% ankommen. Ja, und da muss man dann operieren. Und wenn es mit einer einseitigen Facettektomie nicht funktioniert, dann muss man es halt eben von beiden Seiten machen. Ja, und zwar so lange ein Release vom Dorsal vornehmen, bis man die entsprechende Mobilität hat. Und wenn man, sagen wir mal, das Ergebnis dann immer noch nicht hat, dann sollte man auch nicht scheuen zu sagen, okay, dann muss ich halt eben auch ein ventrales Release machen über ein NIS. Dann ist das so. Und dafür muss man ausgestattet sein. Ja, man muss also sämtliches Instrumentarium muss man vor Ort haben. Ja, dass man sagen kann, ja gut, dann mache ich halt eben ein. Ja, wo ist jetzt das Problem? Dann muss man ventrales Release oben drauf setzen. Ja, und es ist eigentlich auch bei uns so, dass wird zwar jetzt nicht immer so gemacht, dass ich auch sage, für sowas will ich immer ventral mit dabei haben in der OP-Erklärung, ne? Dass man dann eventuell darauf reagieren kann und dann muss man sich halt eben die Zeit nehmen. Ne? Und zum Abschluss kommt ja dann die Schraube wieder raus. Ja, und dann muss das so stabil sein, durch Abstützung mittels Cage, dass es halt eben nicht zu einer Dislokation beziehungsweise zum erneuten Ventralversatz kommt. Ja? Und damit hat das also heute auch schon registriert, das muss ohne Reden sein. Ja? Und genauso ist es abgelaufen. Und ich hatte schon gesagt, das waren noch nicht mal die Top-Leute am Tisch, ne? Sondern das war dritte, vierte Reihe und es hat super gut funktioniert. Und das ist die Voraussetzung. Aber das sieht man dann sofort, ne? Um so etwas zu erreichen. Ne? Also das ist genauso wichtig wie das eigene Können, die Implantate, ja, und die Instrumente ist halt eben das Team, dass es dann einwandfrei funktioniert. Ja? Und jetzt komme ich nochmal zu dieser Zusammenfassung. Es geht wirklich jetzt nur um diesen ganz kleinen Teilbereich der Wirbelsäulenchirurgie, also in der lumbosacralen Verschraubung. Das ist gut etabliert. Ja. Man kann letztendlich die Versorgung bis thorakal machen, obwohl ich da schon sehr zurückhaltend bin. Ja, bei Conus medullaris über lateralen Zugang von dorsal bin ich sehr, sehr zurückhaltend. Ja, der Konus ist also extrem sensibel. Ja, wenn da irgendwas ist, da würde ich mir den Hintern beißen. Ja, dann mache ich dann lieber eine Torakotomie und mit Zwerchfellsplit und gehe dann über den Zugang da dran. Ist mir sicherer. Ja, aber man könnte rein theoretisch TLF bis oben hin operieren. Man kann sehr gut 5:1 operieren, was über einen lateralen XLIF-Zugang zum Beispiel nicht immer ganz einfach ist, glaube ich. Bin da also nicht trainiert drauf, also ich kann es nicht genau beurteilen. Das sind so die Gründe, warum ich mich da ein bisschen zurückhalte. Was XLIF anbelangt, brauche ich auch nicht. Ich brauche den XLIF letztendlich auch nicht, weil der TLIF in dieser Form, wie der jetzt performt ist hier bei uns, alles abdeckt, alles. Ich brauche keinen XLIF. Ja? Und ich brauche auch keinen PLIF. In meinen Augen gehört der PLIF raus, komplett sogar, weil der PLIF den Nachteil hat, dass man halt eben durch den Wirbelkanal gehen muss. Ja, und ich habe von beiden Seiten, weil ich sozusagen keinen Bananen-Cage habe, weil ich habe einen orthograd eingeführten Cage. Ich muss also von beiden Seiten, muss ich letztendlich die Dura mobilisieren, um eine korrekte Implantation vornehmen zu können. Deswegen bin ich auch kein Freund und Verfechter von PLIF. In meinen Augen braucht man ihn nicht. Man soll sogar die Finger davon lassen, gerade in der Revisionschirurgie. Nicht nochmal ran. Einfach die Finger davon lassen. Revisionschirurgie, es ist ja nicht nur die verletzte Dura, es ist die verletzte Arachnoidea. Ja, der Neurochirurg versteht das. Ja, der Orthopäde wird da wieder Schwierigkeiten haben, das zu verstehen, dass es halt eben außer der Dura noch andere Strukturen gibt, ja, die Probleme machen können. Und wenn Sie dann ein zweites Mal rangehen, an eine so schon gestörte Arachnoidea und die dann noch mehr verletzen und dann nicht nur von der primär originären Seite, wo operiert wurde, dann noch von der kontralateralen Seite, ja, dann gibt es richtig Probleme. Ja. Also da sollte man tatsächlich die Finger davon lassen. Das geht alles mit dem TLF. Es hat, hier Surgery, da ein sehr guter Überblick über das Operationsfeld. Jederzeit kann ich das größer machen. Ja. Ich schneide es einfach auf, gib mal das Messer und dann machen wir das oben und machen wir nochmal auf und dann geht man mit dem Finger einmal hier so durch und dann hat man den Zugang, den man dann braucht. Das ist wichtig. Ja, es ist wichtig, wenn ich dann auch eine gute Lichteinstrahlung habe und die Übersicht ist einfach extrem wichtig. Ne? Und das, was ich hier auch nochmal aufgeschrieben habe, das finde ich auch so wichtig, dass man eben diese anatomischen und pathologischen Strukturen, dass man ein Auge dafür kriegt. Man muss das gesehen haben, ja. Und das geht halt eben sehr gut über offene Techniken. Da sollte man dann beherrschen. Und das andere ist, dann ist man natürlich dann irgendwann so weit, dass man es perfektioniert hat. Und dann guckt man nicht mehr so viel rechts und links. Und ich als Senior kann mir das also herausnehmen, dass ich da also ziemlich, sagen wir mal, meinen Weg gehe und ich weiß, was ich damit leisten kann und welche Pathologie ich damit angehen kann, um am Ende ein gutes Ergebnis zu bekommen. Nämlich, man darf eins nicht vergessen, es geht nicht darum, dass ich Punkt 1 oder Punkt A mit Punkt B miteinander verschraube und dann ist gut. Nein, dazwischen ist eine Pathologie. Und diese Pathologie muss ich korrigieren und die muss ich beheben. Das Ergebnis muss sein, dass ich am Ende der Intervention, das bessere Wort als mal Intervention ist das bessere Wort als Operation. Irgendwie so etwas. Es ist eine Intervention. Das Ergebnis dieser Intervention muss sein, dass der Patient nach Hause geht und sagt, es ist alles weg. Und das sieht man sofort, wenn man am Bett des Patienten steht. Der Beinschmerz muss weg sein. Alles andere darf sein. Nur Beinschmerz nicht. Wenn Beinschmerz immer noch da ist, ja, dann wissen Sie, da ist irgendwas nicht in Ordnung. Ja, und dann nützt er hier nicht und da nochmal überlegen und könnte und hier und da. Nein, es ist nicht korrekt umgesetzt. Das ist nun mal so. Ja, und die Sicherheit muss man dann haben. Und es ist nicht einfach. Ja, ich stehe da auch häufig so und denke, ups. Ne? Aber dann geht's los. Da muss man suchen, bis man das Ergebnis hier bekommt. Ne? Und jetzt sind wir zum letzten Punkt. Also ich darf mir das herausnehmen und die jungen Leute, und deswegen war ich auch dann bereit zu sagen, okay, dann machen wir das, lieber Amir, ne? Weil ich der Meinung bin, das ist jetzt sozusagen die Generation, die jetzt kommt, die muss sich damit befassen, wie man das also mit weniger Aufwand, vielleicht minimal invasiv und unter Berücksichtigung aller technischen Möglichkeiten, die es ja heute gibt, ja, das umzusetzen. Und da bin ich schon der Meinung, das ist der richtige, das ist der zukünftige Weg. Ja, das wird so sein. Der wird nicht einfacher und nicht schneller gehen als das, was ich da durchgemacht habe. Sie werden auch ihre, was weiß ich, 15, 20 Jahre benötigen, um das also komplett umzusetzen. Ja, es wird auch nicht schneller gehen, aber man muss daran arbeiten und das dann auch zu einem guten Erfolg bringen. Da bin ich mir ziemlich sicher, dass das funktionieren wird. Das glaube ich schon. Also wenn ich das so manches Mal sehe, wie das alles so vonstatten geht, dann denke ich schon, interessant ist es schon. Ja, interessant ist es schon. Und ich glaube, soweit bin ich dann mit meinem Teil fertig. Ich wollte in der Reihenfolge einen kleinen Wechsel machen. Ich würde mich also freuen, wenn wir jetzt mit dem OLLIF weitermachen könntest. Und das andere ist ja so ein bisschen außerhalb des Themas. Das könnte man dann vielleicht als Ergänzung mal machen.
Oh,
Ja?
gut.
Ja.
Gut. So, danke schön. Ich brauche ein bisschen Elektrizität hier. So, I'm going to thank you. First of all, thank you very much for having me here. I'm going to keep the talk in English because that's the language I'm more comfortable with to give this talk. And secondly,
Use here the pointer.
yeah, that's great.
We have to maybe here is the big one.
Mm-hmm. Here we go. Okay, thank you. I'm not sure if we need to show that. Oh, before this dance, I'm just going to. So. Need to get adapter here. Okay. Well, first of all, thank you very much for having us here. It's been a pleasure to be here, and it was great to see that surgery. We did a surgery in literally 1.5 hours. Now, first time I was learning a TLIF, it was I think about 2007. We needed 7 hours to do that surgery. The person who taught me to do TLIF, we did together, and my attending needed 7 hours to do a vulnerable TLIF. And that was the standard. I mean, that wasn't anything unusual. And obviously, with time and with technology, we got better. So we do, in average, this is the data. In the United States, an average TLIF is about 2.5 hours. We did way faster than average surgery in the United States. But about 12 years ago, I started doing some different kind of surgeries, like XLIF, ALIF. Now, I totally agree with the ALIF. ALIF is a beautiful surgery if you have a good team. It can be a disaster if you don't have the right team and technology. So, but let me just see if this doesn't want to work. Let's see here. First of all, this is the statistic. In the 1990s, lower back pain was number 3 reasons for disability in the United States, and in 2015 became number 2 globally, including the whole world. It wasn't among top 10 in 1990, and is now in 2015 was number 4. But I think more importantly is that it is now number 1. So this is a big deal. Spine and spine-related problem are big deal. This is not a rare condition. It affects everybody. And the reason for that is extremely simple. People are getting older and they want to have a quality of life. For my parents, it was normal not to be able to walk the last 5 years of your life. We don't tolerate that anymore. The people are getting older, their spine is getting worse. Now, this is the reality. By the time you're 50 years old like me, there's only 32% chance you don't have spine problem. By the time you are 70 years old, there's only 1% chance you don't have spine problem. Not all of them need surgery. We help many of them without surgery. As a matter of fact, this is our duty to help most of them without surgery. And when they need a surgery, they don't all need fusion. It's a fact. We can help many of them without the fusion, but percentually, some of the disc will look like that. Who is going to patch that? Right? So the number of the cases that we need, I agree, we need to do the right surgery for right patient. And then the question about are we doing too many or too little is irrelevant. More importantly is if we can help the patient, no problem. Okay? Now, I'm not going to go through this, but I'm not sure if you guys knew that. Amanda found that we have done 1.62 million fusions in the United States. Is it too much? Is it too little? And so on. But this is the fact. This is the fact. We are doing this, and we cannot afford to continue with current technology. People are getting older. They want the surgery. We are providing it. With current technology, we are hitting a wall. Something else has to come. And that I'm hoping today show you that something else. And it's not about the skin incision. Okay? This surgery to this surgery is not about the skin incision. So I was very happy to see that you actually preserved the muscle. You didn't just strip the muscle off the bone and they completely destroyed the vascularization of the bone, because those things are important. Now, this is the dirty secret of spine surgery. If you're not a spine surgeon, just don't listen to this part. This is just among spine surgeons. Which of these muscles do we reattach after you have done spine surgery, a traditional one? Once we cut them, we don't reattach a single one. Okay? So we destroy all of them. Imagine you do elbow surgery. Most of you are orthopedics. You do elbow surgery. At the end of the surgery, you don't want to reattach the tendon. You're practically rendering that joint unstable. And this is another important fact. That is why my patient walk within 2 hours and go home. 96% of my patients go within 24 hours. And people who are young go back to work within days. So the regulation of are through two apparatus, muscle spindle and tendon Golgi apparatus. When you cut the tendon, you're disrupting that autoregulation. So practically, the day after the surgery, muscle won't contract, but never get the signal enough. It goes to spasm, and this patient needs a long time to recover. It takes them a long time to be able to do regular activity, and this is important. We talked about that last night. There is no artery of L4 or L5. The vascularization of all our bones is through surrounding muscle. In a traditional surgery, we are stripping the muscle of the bone, and guess what? The studies are clear. If you do traditional approach and go to lateral gutter to transverse process, you have reduced the vascularization of the bone to the 25% of the original value. And now you are surprised why bone doesn't heal. Now, do you want to see how it looked like then in a real person? That is how it looked. This is my patient. I did a 2-level OLLIF in 2012. I did a 1-level adjacent segment in 2014. In 2015, patient had a car accident. I had to take the patient back. People who know nothing about the spine, they think, oh, look at this beautiful tissue. What is this ugly stuff? But the spine surgeons say, look at this ugly avascular scar. And look at that pristine tissue, scarless, pristine tissue. That is what makes them go back to work so much faster, because they don't have too many injuries to recover from. And do you know how it looked like inside? This is MRI of a patient with a tumor. Traditional tumor, not your way of killing. Not the Vilsky tumor. This is scar. This is the abdominal muscle. This is how abdominal muscle looks like. This is scar. And now the second dirty secret of spine surgery. This is my patient. The L4-5 OLLIF 2 levels above the multifidus muscle scar. Did you guys know that? You know, spine muscles are multisegmental. If you do a 1 level TLIF, 1 to 2 levels above and below, you're creating the muscle turning into scar. So, and very, you know, you talked about it beautifully. You cannot do a 6-hour surgery. Well, you can. Patient wouldn't benefit much from it because now the surgeon, we know that. Anesthesiologists, they talk to anesthesiologists about how they feel about that. But this is quantified. This is not a gut feeling. We know about that. This is about 400,000 surgeons study. Amanda will make sure that you get the reference to all the pictures. Every additional half an hour on the anesthesia is 17% additional combined risk of the surgery. And that is for every surgery, independent of what kind of surgery, just the anesthesia time. And this is for everybody. People who are prone, that rate is even higher. Long story short, so if you put all the surgeries on in 2 hours in one group, all the surgeries over 2 hours in another group, you're doubling the complication risk. That includes infection, that includes heart attack and pneumonia. You're doubling that. So I totally agree. We shouldn't be doing PLIF anymore. We have better things, okay? But let's understand, you know, that do you guys know Trabi, right? Trabi, the car. Would you drive it today? You wouldn't. PLIF is 1950s method of surgery. It was good in 1950s. Trabi was good in 1970s. But in 2023, you should have better cars to drive. So 1950, obviously true harm TLIF is 1980s. And then obviously we got better and better technology has made a huge difference. Now we do MIS TLIF in 1.5 hours. That's fantastic. Now, ALIF, we talked about that. It's a fantastic surgery. I have done over 130 of them. And if you have a good team, it's a good surgery. It's an access surgery. The part that the spine surgeon does is, you know, not as important as the access itself. But if you don't have the right team, that could be a disastrous surgery. And then obviously in 1990s and 2000, lateral approaches, they went up in number. Just the fact is they are coming down in numbers. For whatever reason, people do that and then they quit doing it. I'm not going to go there because that's a different part. And obviously for last 10 years, we do OLLIF, oblique lateral interbody fusion, anterior to psoas, where practically ALIF in the lateral position where you are going laterally. The problem with going to the front with the ALIF is that we talked about that there are some small veins behind the iliac vessels. If you don't get them, and if they tear and start bleeding, you're in trouble. Every time you try to coagulate them, the hole gets bigger and bigger. So this is supposed to overcome some of the problems of the ALIF. The number have been stagnating. People do that, and this is a good surgery. Now, by the way, everything you see here, I have done. It's nothing here that I haven't. But I'm going to talk today, obviously not about OLLIF ATP. I'm going to talk about surgery through this thin line here, right there, where I don't disturb the posterior element, but as well, I keep iliopsoas practically undisturbed. And that surgery, let me just move forward, enable with some variation. We have published paper, and Amanda will send you the references. But with some variation, we can do it in thoracic region. We do, these days, actually, another paper is coming out where we modify it. That number has changed. We can go from T5 to S1 to all of that in prone position. And that's a huge advantage. And you don't need to change the position. You heard about that. If you do go front and back, or front, back, front, back, this is a whole day surgery. And I have data to show you. Still is a whole day surgery. So these are our papers. Amanda will make sure you get the papers about that. But I think I want to show you about some variation of the technique. What I'm going to show, I'm going to call it all OLLIF, but we have a method of teaching it. We have really created like a flight school for that. You know what you have to learn first, then you can build on that. second, and it has worked really well for people. So there's a variation of technique that enable us to do that, go from T5 to S1. One of them is so-called the direct lateral in the body fusion, practically prolateral. Instead of being in triangle, you go anterior to the nerve root. I'm going to show you a picture about that. And then there's another we just published, transfer where we punch the outside of the hypertrophy cell to get in. So we will send you the thing, but I'm going to call them all OLLIF for the purpose of this talk. So this, about 2 months ago, these were my numbers. So I haven't done a handful of it. It's not a base. The data I'm going to provide to you is not based on 30 patients or 40 patients. It's based on about over 1,500 patients, about 3,200 levels, 10 years of data, and we have 43,000 follow-ups on this patient that are in this group. So Oswestry and so on, and we have published the 300 group or 1,000 OLLIF group is being published, 1,000 because we need follow-up. So I couldn't publish all my 1,500. So we have plenty of data to show you here. And that's what's based on. Now, the fact is now that on this patient that, in the last 5 years, we do, I'm talking about 1-level fusion to 5-level fusion. If you put all our fusion, OLLIF group together, I'm calling OLLIF, but now that I'm talking about all of them, 40% of them are under 1 hour, and 95% of them are under 2 hours, and 99.4% of them are skin to skin under 3 hours. And then you add half an hour anesthesia. Now, why is it important? Because 3 hours seems to be a magical number. And the rate of complication, which we talked about, increases with the duration of the surgery, just anesthesia time. After 3 hours, it becomes exponential, especially in elderly. So if elderly defined, at least in US, 75 and older, try to do whatever surgery you can do under 3 hours total time for elderly. And that is, if you go above the 3 hours, complication rate, it just skyrockets. One of the places I do surgery, A-level, 2-level, 45 minutes anesthesia, 6 and 9 hours, same day. On the skin, what time they have to me, skin to skin time was under 1 hour, and everybody repeat that. Again, don't walk out of this thinking this is specialty to me. I'm not going to this. This is a university, 1-level. This is 2 years ago. No, actually, 3 years ago, sorry. But still, 1-level fusion, what you just did, 7 hours. You have scheduled the 1-level TLF, not even a difficult level, 3-4, 10:30 to 17:30. This is still reality. And that reality has to change. So, and this is one of the other papers that we published about obesity. This is 388 patients, all the fusion in one hospital. You remember that the time on the anesthesia directly correlates with the outcome. TLF, when the BMI goes up, the time on the anesthesia goes up and the complication goes up. MIS-TLI in a hand of someone who has a 2,000 of it, expert MIS-TLI, 37, that becomes more dangerous, but all stays flat. Now, there's only one more picture I want to show you, and then I want to talk about the technique itself. By the way, we correlated this and reevaluated. This is a second study that shows, even in multiple complex things, complex surgeries, the BMI really is not a factor. We can do this surgery, and we have done this surgery on BMI of 62.5. I'm not sure if you guys know how somebody with a BMI of 52.5 looks like. They are as wide as they are tall. But once the tube is in, it doesn't really matter if you go through 2 inches of fat or 6 inches of fat. So I'm going to show you just one more here, and that is the last I want to show you in the to save time about the studies and so on. Then I want to talk about the technique. But 96% of our patients ambulate within the first 24 hours. That's why they can go home. Okay. We just opened our surgery center, ambulatory surgery center. We did 3 cases just last week. We were done before noon, and at 2 p.m. I went to my surgery center. Everything was empty. All the patients were discharged. This is the reality. When you come, we had visitors, and we put everything, pictures and so on about that. But I'm hoping you guys come and watch this. You see that more impressive than doing the surgery is that patient wakes up. I absolutely agree. The leg pain is gone. That is, we talked about that last night on the dinner. It is just a fact. They wake up and the leg pain is gone, and that's the best sign you can get about your actual outcome. Now, I want to talk a little about the technique itself. And the Cambin triangle is actually called Cambin because Dr. Parviz Cambin invented or evaluated and put the anatomy down 40 years ago. It went to Southeast Asia. They used all the endoscopy, most of the current endoscopy techniques are based on Cambin triangle, which is practically retroperitoneal space. You see the confine of it, and then 2 C-arms. And then lots of people have asked me, can you do 1 C-arm and so on? You can do that, but you don't do in my surgery. You're doing a different kind of surgery, and that different kind of surgery won't have the same performance. So I use 2 C-arm, and there are different way of setting up the C-arm. Downstairs, you will see one of the methods. There's another method that I use for like scoliosis, rotational abnormality, and so on. And this is something that it took me just 200 cases to just figure out what the optimal position of the C-arms are. That is why people who are joining us and learn that they do so much better than I did because they don't have to figure it out. You give them a map of how things should be in the wall. Now, first, we adjust the 2 C-arm to true lateral and true AP. And sometimes for my patient to get the true lateral, the C-arm looks like this. Because patient has torsion, has other abnormalities, and like imagine if this is the patient, so the C-arm looks like this, you get a true lateral, because that's a true lateral to that vertebral body at this space. And then in that picture, then you identify the center of the disc in the AP and lateral. You will see downstairs. And then this is the magic of it. You don't have a direct visual. I did use endoscopes a few times, and you see, but it's really didn't add anything to me. I stopped using endoscope. We even have it. That part, you remember, I have 8 engineers. They love when I go and tell them what they need. They sit in a box and they're just waiting for me to go there. And even they built actually a macroscope, you don't need an endoscope. You put it there, you just you darken the room, you can look inside, see everything. But it didn't really, so we spent lots of engineering time for that, but we quit using that because it really didn't add anything. What you see is on the screens. You use a neuromonitoring probe. I'm going to show it to you downstairs. The neuromonitoring probe is insulated with Teflon all the way to the tip, and then there is a sleeve over it. The sleeve is to keep the trajectory after you are where you need to. And this is something I learned the hard way, that don't aim for the Cambin triangle, aim for the pedicle below, because that's the best visible structure, and then you just slide it then down. All of you know that the nerve root is attached to the pedicle above. Right? And this is where the nerve root is. When you hit this and you write it down, you're the farthest away from the nerve root. And then once your probe is in, I simulate at 3 milliamp, and I go to 4 milliamp. And so I'm good at 4 milliamp, or we have validated that's good enough. Then the sleeves come down, the probe comes out. I will show it to you downstairs, and I'll show you a video as well. Then you have this small little sleeve, then a K-wire goes in. Over the K-wire, the dilator goes in, and then over the dilator, practically the dilator itself is 8 millimeter inside, 10 millimeter outside, and this is now where the discectomy comes. Okay? All about instrumentation. Somebody told me, actually an MIS surgeon, I don't want to call the name, in one of the conferences where I was presenting that, told me that they tried that there is no way you can do a discectomy over 8 millimeter tube. And my answer was, it is impossible to fly without wings. Well, more or less. So it's about instrumentation. If you don't have the right instrumentation, you cannot do the surgery, okay? But this is the instrumentation. This is actually a good selection of the instrumentation. You will see them downstairs. There's some other instrumentation that I don't use all the time, so I didn't bring them with me. But you would be surprised how little you need to do the surgery. You see, beside what you will see downstairs from the hospital, I need a patient, I need a bed, I need 2 CR, I need neuromonitoring, and I need a scalpel, and then I need something to close the skin. That's all I need. I don't use bipolar, I don't use bovine, I do not use suction. Our blood loss are draining the sponges before and after. And this is all you need. And can you do this hysterectomy? Yes, you can. As a matter of fact, once you get used to that, we have some surgeons that still do open surgery, and I do sometimes open surgery. But once I have even if I'm my open surgeries, I open it a little for my open TLFs. I put the dilator in, I put that tube in, then my nerve root and the dura is protected. Then I can go with my sharp instrument in and out without being afraid every time I'm going in and out. Like we talked about the risk of durotomy, the literacy says about 8% or so. And because you go with the sharp instrument, especially if you have a redo or revision, it's skyrocket. Knock on the wood, I never had it to 1,500 cases. I haven't had a single durotomy. It would be really strange for me to have one because I'm extraforaminal. I have to be really, really wrong to have a durotomy. So, and you can control the position of the cage. By putting the cage front and back, right and left, you can correct. Matter of fact, we wrote a paper about it. You can compare pre and post-operative CT. You can correct 5 to 7 degrees per level. Why is it important? Because pre-op, let's say scoliosis is 35. When the patient stands up, you add 35% to it. But in post-operative CT, if the scoliosis you correct it from 35 to 12. That 12 stays because you have instrumented. Now, do I want to correct everything? I used to try to correct the films. I always had to do bigger surgeries and take more risks. Now I don't. I try to do the minimum surgery. And this patient surprisingly do well. And we have, so diffusion. Diffusion occurs in a higher rate. We talked about that last night on the dinner. I did not believe when 2 independent radiology read my fusion rate about 98%. But other muscle sparing techniques, like even Wilson's technique, have proven if you don't disturb the vascularization of the bone by stripping the muscle from the bone, the fusion rate is in high 90%. This is not even specific. It is not specific to me to have fusion in higher 90s if you don't disturb the vascularization of the bone. So I'm going to stop with the OLLIF talk and then maybe answer you a few questions here. And but more or less, if you need more information, you see, I have 135 slides there, and this is the slide number 44. I have lots of data, but I'm going to stop here, answer some questions, and talk maybe just 5 minutes about something that you cannot avoid, especially you younger guys who are here. You're going to have hopefully 30 more years, 40 more years of your practice. What I'm going to talk to you about is the hottest thing on the. Amanda? Who is the hottest celebrity in the world right now? MK, Kim Kardashian. So I'm going to introduce to you the Kim Kardashian of musculoskeletal. So just for 5 minutes, okay? You can know Kim Kardashian of musculoskeletal. It will have impact on your personal, not professional, on your personal life, and I'm going to tell you why. Any question regarding the OLLIF before I introduce you Kim Kardashian? No? Anything you want to know about outcome, critiques?
I started also with, for example, the big slip procedure. Did you have cases in which the indirect decompression was not sufficient and you had to go in?
Absolutely. the great question and most important question. This something that can be used for every patient? Absolutely not. This is not for everybody. But what you can do with this, it depends on your level of experience. I do grade 2, and I don't do really grade 3 listhesis with this, but I do grade 2 listhesis, but I didn't start doing grade 2 listhesis. I'm in many of the grade 2, if the stenosis is very big, I do this, and then I do a 1.5 inch, 3 centimeter incision. I go it down, and then I do a direct decompression. In some cases, when there is osteogenic stenosis, I do a laminotomy. I don't do laminectomy. I do laminotomy. I go unilateral, unroof the lamina. I decompress the contralateral side first, take the flavum as I'm coming to my side, and do ipsilateral decompression, and then wait. Sometimes they get better. If they don't, then I go there, I can fuse them. I already have done direct decompression. I don't do osteogenic. If there's a truly osteogenic now stenosis, it's not the right thing. Now, the rest of it is depending on your level of experience. Like, and it took me 700 cases or 500 cases before I did my first grade 2 spondylolisthesis with this. Dr. Gasco is doing grade 2 spondylolisthesis after 50 cases, but he doesn't, that is his advantage. He didn't have to gather all my experiences and add to it. He's gathering, he got all my experience. I literally went to him, swapped him with him. We did actually 20 cases together, and then he did more and more. So his level of experience his learning curve was much steeper because he didn't have to go through law. This is not one surgery that can be applied to everybody. Now, having said that, there were 13 patients that I thought this surgery would be good enough, and I consent all my patients. I tell them that, sometimes it's not good enough. You have to go and do a foraminotomy or something else. For 13 patients that we had this surgery, and within 3 months after the surgery, I went back, I did a direct decompression, but 13 from 1,500 patients. And 5 of those patients, they had an accident, they fell, it did something else happen. So it wasn't just the procedure itself. Yes.
Do you have any problems with the nasal? I think the key wire is crossing the nasal.
So
leaving a narrow
nerve root irritation is an important part of the surgery. Let's go over all the complications. Nerve root is one, right? So it's a big deal. That is the reason it didn't cut off, because in the learning curve, you have a high rate of nerve irritation and damage, and people quit doing that. But let's go over all the complications, not only nerve, because that is, I think, we should be aware of. Now, let's start with the most important one, infection, right? The United States risk of infection rate is 3 to 5%. My infection rate has been 0.3%. 3 infections, all of them responded to 5 days of oral antibiotic, not a single take after surgery. Number 2, intraoperative and postoperative bleeding, right? In the retroperitoneal, I had 3 patients with the retroperitoneal bleeding. None of them was really to a point that needed blood transfusion. One of them, all the vitals were good. The hemoglobin was 9.7, but everybody was scared and they transfused anyway, but they didn't really need that. Patient was stable, but it can sometimes bleed into the psoas muscle. And there is obviously the other vascular injury. I haven't had any other vascular injury. And the reason for that is I have more vascular injury in my life with sketching than with this. And the reason for that is I shoot a lot of X-ray. I see at any moment the tip of my instrument. So that is low. Now let's talk about the durotomy. Some of you have talked about, but you weren't for the dinner last night. What is the rate of durotomy generally in the fusions? Skill of twist. About actually durotomy is reported me, I say very good, actually about 8%. A little over 8%. If you do complex cases, absolutely is higher. My rate of durotomy, not again, has been 0 to this day. Now, let's talk about the nerve injury, nerve problems, okay? This is a tricky question, but if you go and read the papers, and I did that, Now, nobody reports early result of the nerve mutation. Everybody hush hush, but they report 1 year rate of nerve irritation and nerve damage. Does anybody want to volunteer what that number is? No, there are variation. It's huge variation. Like XLIF, it can be up to 35%, especially for 4, 5, and so on. And so this has been reported from 0.3% to 35%, the risk of nerve damage after all surgeries. Like some surgeries, if you do redo scoliosis and so on, it has been, let's go back, one step back. A paper came out, the previous paper from 2016 put the complication rate of long stretch scoliosis at what number? What is the rate of long stretch scoliosis if you put all the complications together? The United States, I don't know, that paper was United States. 40%. Another paper came out, it's 60%. Okay, let's talk about that now. Nerve irritation is part of it. Okay, the 1 year results has been reported from 0.3 to 35%, but an average damage is 1 to 3%. That is what's reported. Now, but nobody reports early results because, first of all, those people are so miserable. If the foot is numb, it's not their problem. They don't talk about that. But we did a systematic review of that. Literally, I knew I'm going to do this procedure 6 months before. We went to every patient. I know you're miserable, but quit complaining. Do you have numbness there? Can you move this up and down? And so we did a systematic exam, I mean, I'm guilty as charged. How many times do you really go after the surgery, really examine every segment, every system, and so on? You don't. We did that. My rate of initial temporary nerve problem with the TLIF was 12.3 or 2%. My rate of initial problem with the OLLIF was 8.5%. And that included my initial learning curve. But there's a problem there. The TLIF guy is miserable. He's not going to complain about the numbness on the top of the left foot. But the OLLIF guy is ready to go home. He's standing there saying, I feel great, but doctor, what's going on with that numbness on top of my foot? I didn't have it before the surgery. They're just miserable enough that the same way that when you're sleeping in the night, you hear the ticking of the clock, but during the day, you don't just dismiss it. They pay attention to that. So we consent the patient for 12 to 15% risk of nerve irritation. In reality, is much lower. And within 2 to 3 months, most of them get better. In our study, which were 300 patients, after a year, only one patient had significant weakness and neuropraxia related to surgery. So that put our rate to that 0.3%. But there were 4 other patients who had non-limiting sensory deficit, meaning they have numbness and numbness, but they say, yeah, I have numbness, but it doesn't really move. So 0.3% permanent damage from the surgery after 1 year. Initially, it's much higher. And we talk about that there are techniques to reduce that. And that is the real risk of this surgery. But on the other side, you don't have a 5% risk of infection. You don't have 8% risk of, and you can't do it for 80-year-old people who other people have rejected with the surgery. So this is now Kim Kardashian. Any other question regarding OLLIF? Yes. Oh, okay. Just, I want to talk 5 minutes, then we can do a pause. Okay. Okay. And 5 minute break, and then we come back, talk another 5 to 10 minutes max about this, and then we go downstairs. Okay? Okay. From the right. I do it all the time. I only do from the
only from the left. When the leg pain is on the right,
I still go from the left,
ah,
but I put the cage all the way to the
Yeah.
other side. I don't, now, the initial, I did go from the right, the pain was from the right. Go from the,
my favorite side is the left one too,
yeah.
like you. And mostly I will do it by the left, but when the leg pain is on the right side, in my opinion, you have to do it from the ipsilateral side, from the right side. And 2 or 3 weeks ago, I had a problem because I forgot it, which side was the bad one.
Yeah,
And I used my favorite side for the left, yeah. And I asked before I began the operation, I asked the anesthetist which side. Oh, I don't know, but maybe it's the left one. Okay, I believed it, and yeah, it just worked. It didn't work. Yeah. So the pain. There was no pain on the left side. I attached the bone and the cage, but on the other side there were more pain,
yeah.
a lot of, and
Maybe
I had to remove all. I had a really big.
So, in the,
Yeah.
thank you. Both of them.
Damage.
He's taking care of me. Do you see that?
That was not brutal damage, and the patient had a lot of pain ultimately after the procedure, and
Both sides.
only on the right side. Yeah.
So I started doing this that exactly like that. The first few hundred cases, if the pain was more on the right, I would put it on the right. If do it on the left, I would put it on the left. But then what I noticed is that, yeah, so what I noticed that it's very, this is technically very demanding. When you change side, it just drives everybody in the world crazy because it's very technical. Everything has to be in a certain place and so on. What I noticed though, with more experience, I can go from the left, I can put the cage all the way to the other side, exactly where I needed to put it. And once I put that, I noticed that I can correct both pain right, left, if both of them get better. Then I
But there's a stenosis in the neuroforamen.
yeah.
And you have to solve this problem by osteotomy in the person.
I don't do osteotomy. I don't take the percent off. That's it. Because I don't take the percent off, and that, let's put it this way, I was very skeptical. You know, when I start doing that, only started doing 10% of my patients. When they have some leg pain, but not much leg pain, mostly back pain. I start doing that. And I was thinking, you know, the back pain get better, but the leg pain probably won't get better. I was very skeptical. So what happened is that they came back and told me, "Doctor, my leg pain is gone." And they came to me and And then I started doing it for more leg pain, and it just not working. Now, I still would go from right and left, but then I did it from the left, and then they have pain on both sides. And they told me the other side is wrong. Then I started doing more to the right side, and the pain was on from the left side. It was for me through a journey. I didn't start doing it. But what's important, so this, you know, they the spinal process, and then they have a torsion. The torsion is to the left, and if I try to go from the left, and I have to be very, very horizontal. Today, that's the only reason I would go from the right side if they have a huge torsion of the
And the other problem is the way lumbalis ascended. This wing is only on the left side, and when you approach it from the left, on the level of L5, Maybe you can mention the vein.
Yeah,
Is that correct?
you can have, as a matter of fact, there's something, we call it, the exhaustive abdomen syndrome, yes.
Ah,
So, and I think that has something to do with that room,
yeah.
that, if you pass more than any complication you can imagine, except great vascular injury, I have them. But, if you pass more than 7 times, and we notice that these patients have
Erstes Item von Flyer und wenn Beispielen
7 pass, that's why we try to
vier.
get the passes, that what correlates
Ja, hier,
with
oder hier.
this psoas weakness and some psoas. So 7 pass seems to be like, for some reason, if you have to poke it 7 times to get it, that rate really jumps up. But before that, yes, I have had some of that problem with the psoas, but just again, technically, because the way they set up over and so on, I tried, every time I tried to do it from the right side, the whole OR goes crazy on me. So what I do now though, I set up everything the same. Now sometimes I do I bend over the table, which is technical movement, but I bend over the table, do it from the right side. The setup is for the left. And then in some cases as well, I go back and forth. So, but that's not it's a small percentage of the patients that I go from the right side. So, now I have lost cages, meaning cages have, gone the wrong way. I had a patient, actually, I want to show you this. This is my most scary cases I have had.
I just give it you back and be more.
Das machen wir jetzt gleich.
Sehr gut.
Sana Baby. Dann Sana auch.
Hallo erstmal. Hab ich schon lange nicht mehr gesehen, ne? Ich sehe mal Ihre Schwester.
Nee, meine Schwester.
Aber
Dann. Entschuldigung, wir sind hier verteilt.
gut verteilt, ja. Haben wir nicht noch ein Foto irgendwie?
Das wird dann.
Und wenn du mal zu
Das können wir hier machen.
this is this was my most scary case.
Video, sorry, I just plugged it out and I use this laptop to have this photo program. If anybody also likes to have the photo, we should do that all together before, and then.
Ist das ganz gut? Vollbild ist.
Das soll man nicht. Ich kenne das nicht.
Ich bin jetzt für YouTube von Vollbildfotos. Ja,
Sehr gut. Gut, dass wir nicht, ja, gut, dass wir nicht haben.
Und ich glaube, wenn Sie sich das alle was vorstellen, die
richtig.
ganze.
Dann holen wir ein Stück von vorne.
Für jeder haben wir eine Lösung. Das ist auch kein Thema.
Okay.
Aber ich glaube,
Ja, das hier.
Hier bei den Mitte.
Ja.
This is kind of words are on your hand.
But you can do that in a way that you have the flyer on the back actually.
And as a professional.
Yeah.
Actually, what I can do is I can take the photo and I can cut you guys out of the photo and fill over the line.
Okay. But you will not completely cut out.
No, like,
Okay,
take
good.
you guys
So
off.
our face is gonna stay over there. That's good.
I can do this in 1 minute.
She's a
Ready? My phone.
It's good.
That's right.
You can do that from that aspect, and then you have it over there. Yeah. 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 Thank you. Yeah.
Thank you.
Thank
Thank
you.
you.
Oh, okay. Yeah. Thank you.
So, okay. Ready, einmal lächeln, einmal hier reingucken und alle Augen auf, nochmal. Danke. Dann sehe ich das auch noch, das wird jetzt so ins reingehen.
Klasse.
Dankeschön.
Dankeschön.
So that is still good. That's gonna be good if we can all together have a photo. Maybe we can just some here and some over there, and you can do it from over there. Yeah. Everybody.
Oh, you know what? You know what? We can go back there, take a picture there, and then we can take that picture.
Yeah,
That's what I'm going to do.
Yeah, we can do it.
Yeah, let's go up there. Keep the picture there. Place that part down and put the-
yeah, I'm gonna photos like that.
Ja, wollen wir das alles stellen?
Ja, bitte.
So let's try and fill it a little bit more.
Okay.
Okay.
Go.
Das losgehen soll, dann sagen wir Bescheid, dann machen wir immer richtig viel.
Ja.
Ja.
That's okay. That's okay. Okay, I can edit this now.
Check.
Do you want to join the group?
You go first with the Children.
Alle Augen auf. Lächeln. Hier reingucken. Okay. So.
William can do it.
Just I would measure 5 to 1 minute. But I wouldn't. Okay, connect that back. So this was my scariest case. I did this for fusion. Patient did really well. Then outside we have lots of ice, fell on the ice, and pushed this cage out. Actually, this is the limits after the surgery. Patient and patient was still doing okay. So I watched the patient for a while, but then in the follow-up, patient was getting actually worse. But pushed the cage even more out. So fell twice. Pushed the cage out, and the radiculopathy came back. I did the surgery, patient woke up, radiculopathy was gone. Fell the first time, it was still okay, some pain, fell again. He pushed it out, the radiculopathy came back.
Here's X-ray. Setting the truth.
I do usually CT. I do CT for most of my patients. It's giving more information than just X-ray. Now, the solution for that cage that was pushed out, I cannot leave it there. So there are two methods of going there. I can go to OLLIF, go from the front. Not my favorite way. But I said, I'm going to give it a try to see if I can do anything different here. So let me just show you what I did here. But again, this is once you get really comfortable. I used the same approach. I went there, it goes a little fast, but then I tried to catch this cage from behind. Same approach. I'm trying to catch it, it doesn't let me. The pituitary, long pituitary. Okay? So now you see I'm able to just touch it, but not really able to catch it. So what I did, I put a Seldinger technique kind of thing. I put the K-wire, put a bend on the K-wire, and you see that bend on the K-wire. I feed the K-wire to the back of the cage, and then I try. It was really scary for me to do that because these are vessels on the front. So I tried it multiple bends, and now you see I'm trying to put that bend K-wire inside of the cage. You see that again, in most of the views. I'm feeding to the cage, and now I'm in the cage. Yeah, it goes a lot back and forth, but now you see I'm in the cage. And then there is a part that I'm going to show you. I feed it into the thread of the cage. You see, the cage is mostly out. As a matter of fact, when I try to put that piece and catch the cage, it starts just turning around. You have to be very, careful with that. Now I'm barely able to catch it back, and I'm pushing it against the bone to the front to be able to thread it more. You see it turning around. Okay, this cage is in retroperitoneal next to major vessel, but the good thing is this cage has very smooth surfaces. Okay, and the vessels, yeah, they are there, but I'm certain they are at some danger. But now I'm turning it to the lower profile. I'll show it to you. The lower profile of the cage, and now I'm pushing it down. Head in, and now I'm able to push it back to the edge of the bone. By the way, I learned from an orthopedic colleague to put the mark screwed by cortical. I was scared of that to do that. My colleague they really swear, and you see now the cage is coming out. Now I'm not going to use the same path with this cage. So I revised it with the cage from the right side now, because now I have it here, everything is in a bad shape, and this angle, I go from the right side, perpendicular to the first side. I put that cage now from the other side. Now,
Excuse me, have you really screwed?
no, I didn't.
That's five, the right one.
No, I didn't do anything to the screws. No, I kept the screw. No, I didn't. No. So, and that's the thing. Now I go from the right side and we now interesting is that we woke up again the panels up there. But I didn't go the same path. I did the other side. Now I put the other page from the other side. Now, what you don't see here, you want to pay attention to that, to the time span. All of that took me 17 minutes. I can go back to the first thing, where I try to catch it to the time that the second page you see, and now pay attention to that as well. You asked me about the expandable cage yesterday. So see,
We had to talk about.
yeah, see, this is where I go in now. I go in with the cage profile on the lower cage profile. Take the cage today in your hand and check it out. I go with the lower profile of the cage. Once I'm in place, then I use a static cage to make it expandable. Why do I prefer that? Did you guys see how it turned? So why do I prefer that? I tried other expandable cage. They rely on sub-millimeter pins to expand. When you put them really to use, many of them, half of them failed on me. They are good in the lab, but when you use it in a real patient, those little mechanical pieces, they all fail. You don't really see the time stamp here very well, but from the beginning of the skin cut to the surgery being done, it's 17 minutes. And then bypassing all the dissection and so on, it really gives you a huge advantage. Now, next 5 minutes, I want to talk about something that I think is important to your sanity. And I don't say that lightly because all want to do the right thing for a patient. And you're all familiar with failed back syndrome, right? Who didn't have a failed back syndrome? Okay, we all have failed back syndrome. What if I told you that more than half of what you consider failed back syndrome is not failed back syndrome? It is sacroiliac joint. How do I know that? Since I have been doing sacroiliac joint, my rate of failed back syndrome is a small fraction of what it used to be. That's something we always dismiss. We don't know it. We don't treat that. And the sacroiliac joint is adjacent Z25S1. And I'm going to show you few slides. That's all I'm going to do. I have 122 slides here. I'm going to show you 5. Give me 5 slides, okay? If somebody comes to you with a back pain, never had anything else before, 22% of the time it's not their spine. It's sacroiliac joint. If they had a spinal fusion, that rate jumps to 43%, meaning if a patient after spinal fusion come back, that's all average, everybody. And they have still back pain, 43% of that is the sacroiliac joint. And not going to go through the anatomy and so on of the sacroiliac joint. But nobody is really doing the posterior medial to lateral open cases for sacroiliac. It's a very traumatic surgery. I mean, people who have done that, they know. Advantage now is that you understand the anatomy and so on good enough so that you can do much better. Let me go back here. This is the anatomy of the sacroiliac joint. But did you know this is a normal sacroiliac joint? Just take a mental picture of this. Any of you have done I have hold the head of the femur in my hand in the 70 years old. That was the smoothest thing I have seen in my life. Something like that in any other joint would be a total arthritic joint, but that is a normal sacroiliac joint. Now, what is the muscle that is a trick question? I'm just coming clean. What is the muscle that acts on both sides of only sacroiliac joint, goes from sacrum to medial? What's the muscle? No, zero. No muscle works only on the sacroiliac joint. All the muscle cross it. They go act on multiple levels. But for that reason, sacroiliac joint We know that the only time physiologically it moves is during the pregnancy. It moves only, you open up open book, 6 degrees, anything above 6 degrees pathologic cause huge problem, okay? Because it is not a viable joint, because it's not a real joint, doesn't have any function, there's a huge variability in it. There is no other joint in human body has so many variability, like some sacroiliac joints are different angle, they're steeper, shorter. Even sacroiliac joint on two sides of the same patient can be completely different because it's not a physiologically active joint. And for that reason, lots of people try to come with the one approach, and it was really difficult to do that. Most of the approach is this. Now, I'm not going to go through all of this, but I want to show you one study that I think is extremely important. That study was done actually in Minneapolis by Dr. Pauly in the university. The randomized trial, the randomized blinded thing is to the who chose which direction to go. And this is the control group. This is the sacroiliac joint fusion group. It was halfway through the study, it was unethical to continue the control group. They crossed them all over to the regular group. They all dropped off in their pain. That is, if you take anything out of this meeting today, just include sacroiliac joint in your differential diagnosis. Just include it. And they're younger than spine patient. They're female more than male. Most of them are athletic. They go for running. They do this and that. They're active enough. They go every day to gym and so on. And then you do provocation tests. If you don't know what they are, go to our webpage. We have a good information material about provocation tests. And then the gold standard of diagnostic has been established by NAS and other organizations is sacroiliac injections. You do multiple injections, preferably 3, but sometimes 2 is enough for some insurances. You put the needle in, you numb it up, but you have to do low volume, contrast informed with the X-ray or CAT scan. And if they get even for a day, even for 6 hours, if the pain, 75% of the pain goes away repeatedly after each injection, even for a short period of time, that's the gold standard of treatment. And then the treatment of that these days is lateral to medial. What do I mean by that? It is, you have to stabilize that joint. And nobody does the open system anymore. I started side bone. You're familiar maybe with the what these plugs. They work well, but I have like lots of revision. Now, at least the initial version was much smoother, didn't have this trabecular thing and so on. I went to screws, I tried 5 different screws. And what you need to know in the anatomy, when you are doing this surgery, you have to adjust get a true lateral pelvic view. The sciatic notch and ala, you have to adjust them. Once you have a true lateral, the entry point will be just anterior. And then I draw the shadows of the sacrum on the skin. Here, and then I have the pelvis tilt, promontorium to the middle of the sciatic notch. I draw those lines, and here is the most of the anatomy you need to know. Greater sciatic notch is aligned, ala is aligned. You see, this is the shadow of the sacrum. You see the remnant of S1, S2. The entry point to the bone in the iliac crest is about, depending on if it's 1 screw system or 3 screw system, it's a little different, but more or less, it's just anterior to the border of the bone in the S1, S2 area. It's anterior to the sacrum because first you have to pass to the iliac crest to get to the sacrum. If you start in the middle of the sacrum, by the time you're through this iliac crest, you are far posterior. Okay? But then this is the so-called inlet view, where the sacrum is the only bone in your body that you can get a true axial view. Okay, because it comes out, you put the cameras as you are depicted here, you get a true. Usually you see three lines, those three regions of the whole, and that's all you should pay attention. Once the three become one, almost then you know that you're truly axial to the sacrum. And then this is the so-called outlet view. A true outlet view is a true AP view of the sacrum. A true AP view of the patient is not going to be of the sacrum, but then you see here the sacroiliac joint, you see the foramen, and then you put screws in. Those steps, once you understand the pictures, the steps become ridiculously simple. And as a matter of fact, the system, I'm going to show it to you today morning. This is all you need to do the sacroiliac fusion. Once you have the views, I put the K-wire to the proper depth, and then the main screw goes in, and it does its own drilling, it does its own tapping, and then you adjust the windows to the direction of the sacrum. And then the second and the third screw, you have to put more than one screw because with one screw it still can rotate, right? Mechanical stability. But then the second and the third screw, they go through the sleeve of the sleeve wire of the first screw, and then they automatically align. Again, this surgery is 15 minutes. It seems to be a long surgery. By not being in a regular surgery, obviously open surgery, nobody does it. That is hours of surgery. With a regular surgery, you put the first screw, then you go again to lateral and repeat everything again. With this, I'm going to show it to you on stairs. Once you put the first screw, the second and the third screw, then you just go to the first screw, you're done. You don't have to go 3 times lateral and come back and repeat the same thing. It's all challenges to get the first screw in. I'm going to stop here, but more or less, and this is actually how it looked like in the patient. That is one of my patients, and it has become very efficient. Now, I'm going to give you a personal story here. Because people are not familiar with that, many of these patients are called narcotic faker, that they have nothing real, because we look into their spine, there's nothing really wrong in the spine. And we just mark them as not real and so on. And this patient, within 4 weeks are off narcotic, here is stand up. When I go to the room 4 weeks after surgery, they stand up, they hug me. I'm not a hugger. They stand up and they hug me because for years they have been told there's nothing wrong with you, it's all in your head. And I do a 15-minute procedure. They're off narcotic, they're back to work, and I have lots of testimonials from them. Okay, so include sacroiliac joint in your diagnostic and do yourself a favor. Just ask the patient, clear their back, and ask them, look at them, do a definition, clinician. Where is your pain? They say, here. They no, don't do that. Use your thumb. Put your thumb. I have to tell them 3 times before they do that. They put your thumb where the pain is. And they put their thumb right here. And you know what it's called, right? It's called the 14 test. If you ask them twice, and they are within 1 inch of the sacroiliac joint, then you have already your 14 test positive. You have to examine them. Do the true examination of the sacroiliac joint is a big deal. You have to take the patient on the table. You have to do all of tests. I know you're busy. You don't have time, but let me give you a giveaway. Okay, I'm going to tell you something that we are validating right now. Then you can send them to physiotherapist to do or physical therapist to do their full test. But this is what we call combined provocation test. Okay. Yeah, you're sitting so well for that. So you did exactly because I asked them exactly to do what we are doing right now, not like this and so on. Just the ankle on the knee, and then you're sitting there, and I hold that stabilizer, and then I push that 3 push down, and every time you put more weight on it, but you have to really push up. Why? Because sacroiliac joint is a very stable joint. Your whole body is hanging on the sacroiliac joint with ligament. It's a very stable joint. You use your femur, I'm using your femur as a fulcrum, put enough pressure there, and that is more distraction and compression and gentling and favor exactly at the same time. We will send you all the information and I will make sure that we have that brochure available for everybody. That test, still you should be doing or send somebody to do that. In the practice, in the real practice, you are so busy, that's too much for us. But the patient shows where the pain is, has the right patient population, and they can, sometimes they cannot even do that. They don't even do that if you don't pay. But then I think, stabilize it here, do that. I hope we don't have security action. So, no, I go 1, 2, and 3. No, it's not about the real. In the back, when I did that, so you don't have to, you're simply combined provocation test together. Okay? So pay attention more to women, especially after delivery. After delivery, when they have a baby, the rate of the sacroiliac joint problem for the first 2 years is 7 times more. Okay? So especially the runners. Okay? Them to have the most comfortable shoe they can have to reduce that peak pressure and so on. That's sometimes help. Obviously, injection can help, physical therapy, gluteal muscle and so on can help. But this is truly a solution for many patients. It is, I'm just telling you, I'm part of many societies for sacroiliac joint. We have 2 names among experts for that. The first name we have for sacroiliac joint, we call it the so-called chameleon joint, chameleon, because it can pretend to be lots of different things. It can pretend to be your hip, it can pretend to be, your performance, it can pretend to be many different things. The second name we have for that, we call the miracle joint, because you do a 15-minute procedure, their life totally changes. Certainly, it has changed my life personally, because how many times I have patients, used to have patients who are angry with me because I did fix their problem, the spine problem, but the symptom didn't go away. Because sacroiliac joint can absolutely create L5. No, you're allowed to have more than one problem. You can have L5S1 problem and sacroiliac joint problem. They will feel the same to the patient. You fix the sacroiliac L5S1 problem, but they have identical symptoms. Because you can have more reason to have that, and then you fix the sacroiliac joint problem, then all of a sudden your feedback syndrome goes away.
So what's your threshold like? When do you make the did you wait? Like, do you need therapy first, or
Yes.
how long do you wait?
I have like 122 slides that shows you what those conservative therapies are and so on. You can do even radiofrequency ablation. You can do injection. When I put my injection, I don't want to numb it up. I put as well steroid in, gluteal muscle physical therapy. Braces are not very successful, or on the lowest level of, they are not as effective. But the behavioral modification for people, especially younger women who have given birth to a baby, sometimes you just have to wait. Many times after spinal fusion, they have a peak, like about 3-4 months after the sacroiliac joint. You have the peak of sacroiliac joint, you put some steroid in there, you reach the time, they come back, they're better, they're gone. Okay? Sometimes you just have to wait and then just support them for that. But taking it seriously, not saying telling the patient, you're crazy, there's nothing wrong with you. That's what my colleagues do. That sort of solidifies their pain symptoms.
Do you use MRI to see like steer or?
Very good question. MRI is not very helpful. The diagnosis of the sacroiliac joint is not a picture diagnosis, the clinical diagnosis. Because sacroiliac joint is so variable, you see horrendous thing on the films that have no symptoms, so it's not a picture diagnosis. If you have to take a picture, get a CAT scan, and you see hyperostosis, you see a vacuum, so-called vacuum effect, the dark in the joint and so on, and you see that some osteophytic changes that it's trying to grow by itself, but it's just not reaching it. But it's no diagnostic, picture diagnostic can affirm sacroiliac joint. It still is required in US to get that, so you rule out tumor or other things.
Rheumatic factors or markers? Rheumatic factors, markers?
No, those are not part of diagnostic. I mean, obviously, people with rheumatoid problem, they have joint problem everywhere. They are higher in the thing and so on, but this has been like a black box. We didn't know about that, but there's what we call Medicare NASS, North American Spine Society criteria. Amanda, please make sure that they get the so-called security adjunct criteria. These are nationally now standardized. So what are the criteria for diagnostic? What are the criteria for treatment? And so part of that is to get spine and pelvis films to rule out that is not something else. Okay. It used to be that we need to have 3 injections for most of the insurances in the United States, but the results are so promising, so good, they went down to 2 injections because they know it works. Okay, and this don't forget this study, and if you can actually read the study, we can make it available to you if you're interested to read the study. This is as solid of a study as you can have. That it was halfway through the study was unethical to continue the control. Okay, and there are very few studies that they do that. That halfway through the study they cross over all the control groups. And what's interesting is look at the result of the control group replicated the initial treatment group identically. Another thing is that you have 2 secondary reactions, right? I do it, there are some of my colleagues that do both sides at the same time. I don't. I do one at a time because I ask them not to walk on that side. If I put them on 2 touch non-weight bearing, and if I do both sides, they don't walk, they have blood clot and so on. But this is one of those magical things. Half of the people that have bilateral symptom, I fix one side, after 3 months, they come back to me, I'm good. I don't have any pain anymore. I'm not going to go to the other side. Because when you fix one side, they can put more weight on it. Then it takes the pressure away from the other side. And another thing that, you listen carefully if they say, it gets worse in the night. It goes from side to side. So younger woman, jogging, running, sporty, and so on. And pain gets worse in the night. Pain goes from side to side. And these are typical things. In the night, you may know, every 20 minutes, you turn from side to side. That's natural thing. You don't remember it. You do it. All the studies, observing. Every time they change from side to side, they twist their pelvis, pain wakes them up. That's very typical, what I hear from all of them. So long story short, include you into your differential diagnosis. I think you had a question as well.
For the patient group that doesn't have lumbar fusion, you told us younger patient, female, night pain also. So I want to ask you to send them regularly to a rheumatologist. Yeah. Because there are some percentage, I think, that you have to fix, but maybe have also a rheumatoid.
Absolutely. They can have your low trans more than one problem. But what I found that, the higher BMI, I see more in the spine problem. These are younger and lower BMI. These are specifically sporty people who are skinny and, they're very, the active and so on. It seems to be that a little different patient group, but once you have the fusion, what that rate is really high. 42%. It's not a low percentage. Any other question?
Yes.
Yeah.
After the surgery, release the pressure from that joint by prescribing crutches or something?
Well, no. Actually, after the surgery, I asked them to walk with a walker. We teach them before the surgery. We don't teach them after the surgery. Okay. Before the surgery, we send them to a physiotherapist, we call it here. We teach them how to do full activity without stepping on that side. But that's only 2 to 4 weeks. It is no different than if you have a knee or ankle surgery, you don't step on it. No different. But for them to take that pressure off, there is a method to teach them how to go about their day. We teach them before the surgery, and we give them a walker for 2 to 4 weeks. Vast majority of my patients tell me after 2 weeks they could step on it and they were okay, especially the new school system.
Sorry, I didn't get you. You mean completely non-weight bearing or just 10 to 20 kilogram weight bearing?
Toe touch, it's established. It's a toe touch, non-weight bearing ambulation on the side of the surgery for 2 to 4 days. But that's something that our physical therapists, they teach them. It's a method. They can go stairs up and down. It's amazing, actually. They can do everything. They just cannot put pressure on it. It's actually amazing that they can learn. You can go stairs up and down that status. You just have to learn it how to do that. Any other question? I will conclude this session. Well, thank you.
So thank you. Thank you. Thanks a lot. Different countries, different viewers, different part of the world, and it was very so hard to plan this event for us. But so we got very good help for and we're gonna have now the practice. So we're gonna have the workshop as hands-on down, stairs down, and I think that's gonna be enough material that we can do that all together, and we have also enough time. We're gonna do that also and we should just take a look. Shouldn't go all together.
No, I think we should go all together.
Yeah.
I like to enter in high level, just show the steps.
Yeah.
And then maybe you can like show you all the steps, and then it's all about the OLLIF part, because
Yeah.
most of you probably know how to put perks, because you are not going to do any of that.
Yeah.
It is, it's going to take, the first few people who are going to do that, it's going to take longer, but if everybody is there and all the questions, all the tricks are answered, then hopefully, when we get to the third and fourth person, there is much more. The repetition is obviously, I think we should go all down there. It's going to be very cozy, but
Yeah, because we are long together, so that's one understand that still long then I know this material we don't have in Euro. We can talk about it.
no, I think no, see, I do if you look at go to YouTube, look at the timestamp, you see I do a surgery skin to skin from the first cut to the last thing in 35-40 minutes. This is not your regular surgery. It's a very technical, very algorithmic. Nothing that is there is something you can buy off shelf. As a matter of fact, yeah, that is where that 8 engineer comes from. When you come to my place, you see that they get the ideas and they build the next building with $1 million machine, and they make it real. Without them, I couldn't do nothing. If you don't tell them that, they get a big head. But true mastery of this is that an idea is worthless in my head. Okay, they make this idea true. Now, you may know that the device market in the US is big. In the United States, there's a huge money because it's just a very rich country. This company who built this, I have to literally twist their arms, and Tony knows all about that, that to work on that to get the CE approval, but they're working on it now. So hopefully within the next 3 months, somebody will come, and there's a huge paperwork to that. They're going to get inspected, they get the CE approval stamp, and then they will start. I'm hoping by the end of summer or the fall, they will have ability to bring the device to the rest of the world. And believe me, it was more work to convince them to do that than because, it is a lot of work to go through that process. Like, even in US, that they're going through the regulatory process to get it approved. All these devices are, by the way, FDA approved, and we have been using it in countries that accept FDA. We are using it in Middle East. We are going to use it in India. We are going to use it in Ecuador, and so on. But Europe has its own kind of different path that we have to go. They have to go through, but they're working on it.
It's just about the catering, it's about also the chip that you use and everything else.
There are different.
Which one is the main part?
There are different paths for something that stays in patient called implantable. versus instrument. So I think the regulatory path for things that stay in the patient is much higher. I mean, I didn't know that, but you have to show where the ore of the metal was mined, in what process. You have to be able to follow in the US, and I'm sure here in Europe is not different. You have to show that which mine in South Africa the ore was taken, which company you have to be able to track, which company made the ore to the metal, which company refined it, which company did the first process making it like a tube or a log, and then you build a thing, and then you have to prove for each one which log they came from. Meaning that what was the furnace, all of that was melted together. Because if there's a problem, you have to be able to go all the way back, say, which truck it messed up and mixed other impurities in that. And so it's a huge field. I mean, you just go to the OR, I mean, true, the surgeon, you go to the OR, just do surgery, and you get upset if a CR is a little here and there. What is in the background of that to make us able to do what we are doing? When I got involved in that, it's amazing, it's unbelievable. For that reason, we have a program that, every single screw that was implanted in all my 1,500 patient OLLIFs, every single screw, what lot it belonged to, and we can go and follow up all the way, step back if there's a problem. And that is the reason why bad things don't happen, like impurities and so on. This is technology is really moving forward. And you guys remember those stainless steel screws and so on? You guys probably don't even remember that, but these stainless steel screws, and some people have problem, not that maybe stainless steel, but the impurities in the metal and so on. And these regulations are made to be able to that you can really verify what people do for. But all of that is in process.
Thanks.
Thank you. Thank you. Yeah, I'm going to. It's very hot down there.
All in your stuff.
Bevor es in den Workshop geht, steht noch es wäre noch etwas Hunger und Durst.
So. Very hot down. Sehr warm. Jacke ist Flugplatzen. Surgery, yeah, I noticed as well, stopping at L1 is not a good shot. But this patient had an injection fraction of 55. Every minute in the surgery was looking at me like a hawk. We're doing surgery. So sometimes it's just you have to take the smaller evil. Something that L1 is not a good idea.
Is that my part?
No, yeah, that is right. Let's go downstairs. Let's see.
I'll go meet you down there.
Yeah. I take my phone like that. Hello.
Thank you very much. But you are is not perfect, it is in the application, to get fresh happening. But it is not a financial thing. The component result of the component of any part of it. This is the goal or portion, and then the knowledge of the Why? Because it's important that the same reason is great. But when how is the beauty of what is and you use the name of the degree that so everything that you know is part of that important. Usually the last video about and then you do that. What is the great ground for the man so that those continue. So very outgoing. But that's very important. Because this joint here is the still, this is the line, so this joint here off. For any, mostly you are going to use the same function, or you are going to use the slide and the money.
let's say I want to do this, and I don't know that you have to do this to a time. Most of them are and we never define the so now the analysis of the but the possibility you have to analysis because the way you look at that is different. So the first thing I think is also identity and complementarity. That means we will know here. I know the way I use it is to out of the people into the world, not related to something, right? But if you do the skills to have something like anything that there are actually one skill that are written up in the field of identity. It's not that So, but again, I think and because I took all my papers already in the textbook, then we can actually do the because my suggestion is not how I want to go to figure. I don't think I think a lot of it. Again, if you have the solution in the random figure, that's how you get it. That is a random figure. More knowledge. The relation is completely young at first, but that means there is more some of but in the album of the relation volume on the social law, the institution typically of the important. So, this is one now. Yeah. Oh.